The patients are going to be having another finding that there is going to be presence of a dry tap on the bone marrow aspiration. So what is going to be seen in these patients is that when we perform a bone marrow biopsy, they would be showing you the presence of cells which are having a honeycomb pattern. Electron microscopically of a hairy cell is what was asked as a question recently. So you're going to be having the presence of cells which are going to be having a hairy projection. What we need to also remember over here would be certain characteristic markers associated with making a diagnosis of hairy cell leukemia. That can include CD11, CD25, CD103, trap stain, that is tartrate resistant acid phosphatase, and the patients can be having the presence of annexin A1. So those are the keywords that we need to remember so far as hairy cell leukemia is concerned. The moment we are thinking in terms of a tumor which is going to be given the name of adult T cell leukemia, it is definitely having an association with HTLV1. That's what we discussed earlier, human T cell leukemia virus. And the tumor cells have a special property that they are having the presence of a clover leaf nucleus, which can be made out very easily by you. So this is going to be resembling just like a flower, clover leaf nucleus. The other ones that I wish you to have an idea is example of conditions that are associated with myeloproliferative disorders. One condition which had been asked as an INA question earlier had been on polycythemia vera. Patients having polycythemia vera are going to be having the presence of a characteristic mutation. That is what we made a mention of earlier as well, JAK2 mutation. These patients will give a classical history. When they are taking a bath with hot shower, then they experience intense itching. So this is what is going to be given the name of aquagenic pruritus. Hot shower bath actually is responsible for causing release of histamine from the mast cells in the skin. So after having a hot shower bath, they are going to be having the presence of intense itching that is called as aquagenic pruritus. Such patients are also going to be having an important finding that there is an increase in the RBCs, WBCs and platelets in them. These patients could be having a discoloration that is given the name of erythromelalgia, and the problem that we encounter in these patients is that this is what is going to be associated with altered functioning, hyperviscosity, because of which there is a high risk of development of thrombosis. Because RBC count is high, it's a polycythemia. RBCs are more in number. So by the feedback mechanism, what we encounter in these patients is reduced levels of erythropoietin. Reduced levels of erythropoietin. Of course, because of high turnover, patients can be having the presence of gout as well. The other example of a myeloproliferative disorder that is asked in the exam happens to be essential thrombocytosis. Essential thrombocytosis is an example of a condition. The name gives a hint. Thrombocytosis, more number of platelets. Platelets are going to be having an origin from megakaryocytes. So this is an example of a condition which is going to be having an origin from megakaryocytes. And these are going to be associated with abnormal megakaryocytes having an appearance which is given the name of staghorn megakaryocyte. Now platelets are going to be problematic over here. So they are dysfunctional. So they are going to be associated with bleeding. But their number is more. So they are going to be also associated with development of a thrombosis-like manifestation. One condition that we need to specifically make a mention of is myelodysplastic syndrome, which can be seen in case of children because of monosomy 7. And a more common cause that we have in the adult population happens to be the complex karyotype. Complex karyotype means multiple cytogenetic defects or chromosomal defects are seen in the patients. That can be something like 5q deletion, that can be something like monosomy 7, and the patients who are going to be having multiple defects in the same individual. This is a condition which is having a peculiar feature, and the peculiar feature over here is that patients are going to be having the presence of increased number of cells in the marrow. So bone marrow is hypercellular, but there is ineffective erythropoiesis. So because of which in the peripheral circulation, you find that there is presence of pancytopenia. Additionally, we need to remember it is not going to be having the presence of hepatosplenomegaly. So hypercellular marrow and the presence of pancytopenia-like manifestation could be resembling just like a leukemia. So the finding is just like too many cells over there in the bone marrow and functional cells are less. But over there in leukemias, hepatosplenomegaly was present. Over here, hepatosplenomegaly is not present. What is seen over here is all the 3 cell lines are affected. So RBCs are abnormal. So they contain presence of the iron type granules around the perinuclear area. So therefore, we are having a finding ringed sideroblast. Remember, where did we talk about ringed sideroblast earlier? Sideroblastic anemia. So myelodysplastic syndrome is another condition where we are having the presence of ringed sideroblast. The other finding that we have in these patients is that they could be having the presence of the megakaryocytes in which the nuclei are going to be fragmented. When there is a nuclear fragmentation in the platelet precursors, that is associated with the term what is called as pawn ball megakaryocyte. Pawn ball megakaryocyte. When you look at the neutrophils in these patients, the nuclei are present in 2 lobes. So 2 nucleolobes are present in the neutrophils. And when 2 nucleolobes are present in the neutrophils, that is given the name of a pseudo-Pelger-Hue anomaly. Pseudo-Pelger-Hue anomaly, that is going to be seen as a feature over here. So a combination of RBC problem, ring sideroblast, WBC problem that is in the form of pseudo-Pelger anomaly, and platelet problem, precursor problem that is in the form of a pon ball megakaryocyte. That is what is pretty much suggestive of a patient having hypercellular marrow, no hepatosplenomegaly, pancytopenia, myelodysplastic syndrome. Now, why are we interested in about myelodysplastic syndrome? It has got a definitive association with PNH. And fact number 2, patients who are having myelodysplastic syndrome can in the future have a progression into an acute leukemia like AML. So that is one of the reasons why we need to be having an idea about this kind of a condition. The other condition that we need to have an idea is the different types of lymphomas. So we have Hodgkin's and non-Hodgkin's lymphoma. As we understand, non-Hodgkin's lymphoma is much more common. Non-Hodgkin lymphoma is going to be characterized by the non-contiguous spread. You have more chances of involvement of the tissues which are going to be associated with over here. Say for example, the spleen is going to be involved. Say for example, the lymph node is going to be involved. The liver is going to be involved. More chances of involvement of something like the tissues over here in case of non-Hodgkin lymphoma, and the prognosis happens to be worse. Different types of non-Hodgkin lymphoma, which we need to have an idea, but not in the exact sequence in which they are going to be developing, but we just need to remember about the more important ones. So we need to talk about something like Burkitt's lymphoma. Everybody most usually remembers the classical image of an African child who's having the presence of a jaw mass over here because of the enlargement of the lymph nodes, and the characteristic involvement of the MYC gene is what is seen over here. The MYC gene that we have made a mention of earlier as well is c-MYC gene. And this is what is going to be present on chromosome number 8. So whenever we are having a problem at the level of chromosome 8, the translocations like translocation 814, 822 and 28, they are the ones which are going to be associated with Burkitt's lymphoma. Read the question carefully. Translocation 922 was associated with Philadelphia. Translocation 821 was associated with AML. Translocation 822 is what you are associating with Burkitt's. Patients who are having Burkitt's especially are going to be having an infection caused by the virus, that is Epstein-Barr virus. And these are the patients who are going to be having in the endemic variant. Remember that in the endemic variant, they are going to be having the presence of the involvement of the jaws. There can be a situation when patients can have sporadic Burkitt's lymphoma as well. In case of sporadic Burkitt's lymphoma, you are having the presence of the abdominal organ involvement. This is an example of a cancer in which there is a c-MYC overactivity. So the rate of proliferation of the tumor cells is very high. This has got two significances. Fact number 1, if you perform a lymph node biopsy in these patients, the lymph node biopsy is going to be associated with a finding that is called as starry sky appearance. Fact number 2, whenever we are having a rapid rate of turnover of the cells, this is going to be associated with an appearance that is going to be a development of a condition that is given the name of tumor lysis syndrome. Remember the same condition which you wish to prevent it. And how do you prevent it? Keep your patient hydrated. Give him drugs which will help in the excretion of the uric acid, drugs like rasburicase. So that's what we need to remember over here. Then we're talking about a cancer asked in the exam that is given the name of follicular lymphoma. Follicular lymphoma, F for follicular, F for 14, translocation 1418 is present. It's an example of a tumor which is going to be an indolent tumor. It is going to be associated with grossly and microscopically you can have the presence of follicles over here and can be picked up with the help of a marker. The classical marker that is asked in the exam, as we made a mention of in our discussion of cell injury as well and neoplasia as well, as BCL2, follicular lymphoma. The third one that we need to have an idea is what is given the name of mantle cell lymphoma or mantle zone lymphoma. There is going to be a translocation that is translocation 1114, right? So as rightly said that when you are going to be having two individuals in the family, be it siblings or otherwise, which are going to be having less gap between them, 11 and 14, they are going to turn crazy, right? And the cancer is going to be characterized by the fact that it is going to be diagnosed with the help of flow cytometry. Now the characteristic feature is what you need to remember over here. CD5 is positive, CD23 is negative, and cyclin D1 is positive. CD5 positive and CD23 positive cancer, as we discussed earlier a few minutes back, friends, was CLL. 5 positive, 23 negative is a feature of mantle cell lymphoma. Mantle cell lymphoma is also characterized by the fact that there is going to be expression of a molecule that is given the name of cyclin D1. Cyclin D1. Sometimes patients are having mantle cell lymphoma, but cyclin D1 is absent in them. In such a situation, we use an alternative marker, and this alternative marker is given the name of SOX11. So for cyclin D1 negative mantle cell lymphoma, we have a marker that is given the name of SOX11. That is what is to be remembered so far as a mantle cell lymphoma is concerned, right? Whenever we are going to be making a mention of a marginal zone lymphoma, both are M's, mantle cell and marginal zone lymphoma. Marginal zone lymphoma is going to be characterized by translocation 1118. It would be classically associated with a history of a chronic inflammatory condition, something like Sjogren's syndrome, something like Hashimoto's, something like H. pylori associated infection. In this condition, when the patient is going to be having an association with H. pylori, we would be using an alternative term over here, which is given the name of a mall tumor. Tumor cells over here are going to be negative for CD5 as well as 23. The most common subtype of non-Hodgkin lymphoma, that means the one which is going to be having the highest prevalence, happens to be the diffuse large B-cell lymphoma. This is an example of a non-Hodgkin lymphoma which may have multiple markers, but one of the characteristic one happens to be BCL6. Usually what happens is, patient is initially having some other type of a non-Hodgkin lymphoma, let us say follicular. Let us say the patient is going to be having then a gradual progression, acquisition of more mutations, and then it progresses or converts itself into a DLBCL. This kind of a cancer can be associated with a virus like HIV, or it can be associated with Epstein-Barr virus as well. It is also having an association with human herpes virus 8, and if you can recall, human herpes virus 8 was having an association with primary effusion lymphoma. So, when it question says associated with immunodeficiency, it is associated with HIV. In general, we know non-Hodgkin lymphoma is associated with EBV as well. And when it specifically makes a mention of the association with human herpes virus type 8, then remember the associated lymphoma, that is primary effusion lymphoma. Next example of a malignancy that we need to have an idea is given the name of anaplastic lymphoma. Anaplastic leukemia/lymphoma is associated with ALK gene involvement. And the characteristic feature over here is that the patients are going to be having the tumor cells which have a nucleus which is going to be resembling just like a horseshoe. So horseshoe shaped nucleus. Sometimes if you look at the nucleus, it is going to be having an appearance like this. So it is going to be helping you remember about the anatomy days. You will be able to recall an example of an embryo-like structure. So embryoid nucleus, horseshoe shaped nucleus, that is a typical feature. That's a characteristic feature of the tumor cells. And these tumor cells are going to be given the name of hallmark cells. So anaplastic lymphoma leukemia associated with hallmark cells, embryoid nucleus or horseshoe shaped nucleus. That is what we need to remember over here. Finally, if we just have to take a cue from the link between pathology and dermatology, we'll be talking about a condition that is given the name of mycosis fungoides. Patients are going to be having skin involvement with T-cell lymphoma, and we could be having a situation in which the patients can be having the presence of cells in the blood or they are present in the skin. When the tumor cells are present in the blood, that's given the name of Sézary cells. And when the tumor cells are going to cause infiltration into the skin, that's called as a phenomenon of epidermotropism. And you have formation of a microabscess which is given the name of Poutrier's microabscess. So Sézary cells, when they enter into the systemic circulation, and when there is going to be involvement of the skin, that is called as Poutrier's microabscess. This kind of a condition, mycosis fungoides, would be characterized by the presence of the cells which are going to be having the presence of a cerebriform nucleus. Cerebriform nucleus. So these are the important examples of the non-Hodgkin lymphoma that we need to keep in mind. Of course, we are now going to be shifting our attention to one of the most often asked topics in the exam. That's going to be something which is called as Hodgkin's lymphoma. Hodgkin's lymphoma is an example of a B-cell cancer which is going to be having its origin from a post-germinal center B-cell. Clinical presentation of the patient would be a middle to elderly patient who is going to be having the presence of a fever. He is having presence of the cervical lymphadenopathy. That's an example of a classical painless rubbery cervical lymphadenopathy. Fever can come for many days. Patient becomes an afebrile for many days, again fever for many days, again afebrile. That's what is being referred by the name of a Pell-Epstein fever. Whenever we are talking about this condition, sometimes the patients are going to be having the presence of the minimal involvement of the tissues beyond the nodes. Cervical lymph nodes, mediastinal lymph nodes are most classically involved. Patients can be having a presentation that they are going to be having a complaint of pain when they consume alcohol. Whenever we are suspecting this condition, we would love to go in for something like a lymph node excision biopsy, and the staging is what is going to be given the name of Ann Arbor staging. As per the WHO classification, Hodgkin lymphoma can be having two major subtypes, classical one and non-classical one. The major reason of differentiation is classical Hodgkin lymphoma is going to be having the presence of classical Reed-Sternberg cells. Non-classical Hodgkin lymphoma is not related with Epstein-Barr virus. It is not having the classical Reed-Sternberg cell. So whenever we are talking about the classical Reed-Sternberg cell, let us just have a reminder of the fact classical Reed-Sternberg cells were having the presence of an owl eye appearance. They were having the presence of markers like CD15 and CD30. When we are talking about the four types of the classical variants, the ones that are appearing on your screen, they are the ones that you need to keep in mind over here. Nodular sclerosis variants, that is commonest in the world. It is going to be associated most frequently with the involvement of the mediastinal tissue. it is also going to be having the presence of Reed-Sternberg cell, which are going to be having the presence of an empty area. So perinuclear empty appearance, that is why it is going to be associated with a modified Reed-Sternberg cell, which is better called by the name of a lacunar cell. The more common type of variant that we have in the Indian context or the Southeast Asian population is mixed cellularity Hodgkin's lymphoma. This type of Hodgkin lymphoma is going to be having the presence of a classical Reed-Sternberg cell. This is going to be associated with Epstein-Barr virus infection as well. It is going to be associated with the presence of eosinophils in the background along with other cells like the lymphocytes. And it is going to be having the presence of lots and lots of non-specific B symptoms like fever, weight loss. Whenever we are making a mention of lymphocyte-rich subtype of Hodgkin lymphoma, it is more commonly seen in case of elderly people, and it is characterized by the fact that patients are having the presence of a single nucleus Reed-Sternberg cell, mononuclear Reed-Sternberg cells. Finally, in a patient having a history of HIV infection, there is going to be a presence of a variant of Hodgkin's lymphoma, which is given the name of lymphocyte-depleted Hodgkin's lymphoma. Because of immunosuppression, the cancer is going to progress much more rapidly in these patients, and therefore they are going to be having a worse prognosis. Atypical histiocytes can be seen in these patients, which are referred by the name of Hodgkin cells. Now, if you look at the 4 examples of the Hodgkin lymphoma appearing on your screen, friends, nodular sclerosis, mixed cellularity, lymphocyte-rich, lymphocyte-depleted, out of these 4, the one which is going to be having the better prognosis happens to be the nodular sclerosis variant. So, it is common in world, involves mediastinum, has a lacunar cell, has a very good prognosis. Overall, if we talk about all the 5 variants, 4 classical and 1 non-classical, the non-classical variant is what is going to be given the special name. The non-classical variant is called as lymphocyte predominant Hodgkin's lymphoma. Lymphocyte predominant Hodgkin lymphoma is going to be having the presence of a situation wherein it is not associated with Epstein-Barr virus. It is less aggressive, so it is going to be having excellent prognosis. The Reed-Sternberg cell in this situation is going to be having a special name. It is called by the name of a popcorn cell. So it is having presence of multiple indentation on the nucleus, so it is given the name of a popcorn cell. The markers by which we can possibly pick up a lymphocyte predominant Hodgkin lymphoma can be markers like CD45, and we can be having a marker like the epithelial membrane antigen as well as BCL6. So 15 and 30 are not present over here. As an alternative, what are the markers present over here? CD20 is present, and we are going to be having a marker like BCL6 and 45. So no association with EBV, very good prognosis, less aggressive, atypical Reed-Sternberg cell called as popcorn cell. This popcorn cell is also referred by the other name of a lymphohistiocytic cell at times. That is what we need to remember over here. Hodgkin's is an example of a disease which has made tremendous progress so far as the management is concerned. And nowadays we are having the novel therapy over here apart from the classical drugs, which is in the form of immune checkpoint inhibitors like nivolumab and pembrolizumab. Just for the sake of completion, making a reference to one of the important examples of the conditions asked in the exam, that's a condition that is given the name of Langerhans cell histiocytosis. Just like the condition of hairy cell leukemia, this is also an example of a condition in which we are having the presence of a BRAF gene mutation. The tumor cells over here are characterized by expression of CD1A, CD68 and HLA-DR. We are having the presence of electron microscopic appearance of granules, which we talked about time and again, Burbeck granules. Burbeck granules were having the presence of a tennis racket appearance. Tennis racket appearance that can be made out over here. So we are going to be having the presence of cells, which are going to be having the presence of a tennis racket appearance. That is what we need to remember over here. Another thing, that Langerhans cell histiocytosis would be having the presence of tumor cells, which are going to be having the presence of a very specific marker, which is given the name of Langerine. CD1 to CD207 is what you need to remember associated with the term Langerine. It can be having multiple presentations, which can be in the form of either eosinophilic granuloma, that is going to be seen in case of a child less than 8 years of age, multiple lytic lesions in the skull, right? If we are talking about a child less than 5 years of age, we can be having the presence of a condition that is called as Hand-Schuller-Christian disease. Hand-Schuller-Christian disease is going to be having the presence of a triad. The triad would include patients who are going to be having the presence of lytic lesions. So bony lytic lesions. Patients are going to be having eye involvement, exophthalmos, and patients are going to be having the presence of diabetes insipidus. So lytic lesions, exophthalmos, diabetes insipidus. Very small children, less than 2 years, can be having the presence of a disease that is given the name of LS disease or Litter's severe disease. These patients are going to be having again lytic lesions, that's important, and the patients are going to be having the presence of hepatosplenomegaly and dandruff, that is seborrheic dermatitis. So lytic lesions is something which is common finding for them. In case of Leiter severe disease, you are having seborrheic dermatitis. In case of Hand-Schüller-Christian disease, you are having the triad, diabetes insipidus and exophthalmos. And in case of eosinophilic granuloma, apart from the lytic lesion in the skull, you are also going to be having the presence of the beveled margins, right? That is what you need to remember. Congenital Langerhans cell histiocytosis is known by the name of Hashimoto-Pritzker disease. That's an iron question that is just we are supposed to be remembering and revising over here, right? So that's about the discussion of Langerhans cell histiocytosis. Now, having a word about multiple myeloma, even though presuming that it could have been covered with you in orthopedics as well, multiple myeloma is a clonal proliferation of the plasma cells, because of which the patients are going to be having in the serum protein electrophoresis the presence of a spike pattern in the gamma globulin area. That's what is going to be given the name of a church spire pattern. This kind of a peak is what is going to be given the name of an M spike. The M spike is most commonly seen in multiple myeloma because of an antibody that is going to be IgG antibody. And one of the reasons is that there is overproduction of the lambda light chains over here. When we are talking about this condition, the origin of a multiple myeloma is from a plasma cell, and one of the single most important prognostic factor happens to be the levels of the serum beta-2 microglobulin. Of course, with respect to the clinical features, patients are going to be having the presence of the clonal proliferation of the plasma cells. So you have to show a percentage of clonal plasma cells more than 10. You follow what has been given the name of the Crab criteria. There has to be a demonstration of hypercalcemia, renal dysfunction, normocytic normochromic anemia, and the presence of punched out lytic lesions, which can be causing involvement of the vertebral column. It can be seen in the X-ray as well. And microscopically, you could be having a finding in which the patients are going to be having immunoglobulin inclusions in the nucleus as well as cytoplasm. So certain terms that you need to be familiar with: flame cells, Russell body, Mott cells, and Dutcher bodies. They're all terms that you associate in a patient who is going to be suffering from multiple myeloma. Please remember, because of hypercalcemia as well as because of myeloidosis, patients having multiple myeloma are at high risk of suffering from chronic renal failure. Apart from the presence of the Crab criteria, we do have the presence of what is nowadays given the name of the Slim criteria. Slim criteria. So you may be showing the presence of more than 60% of the clonal plasma cells. You can be showing the presence of the involved light chains in a ratio of 100:1. You could be having the presence of the MRI finding or the radiological investigation showing you the presence of at least a lytic lesion. So these are what are going to be given the name of the Crab and the Slim criteria, and they are being referred by the name of myeloma defining events. They're called as myeloma defining events. That means if they're present, then the diagnosis of multiple myeloma can be made relatively easily. Just for the sake of handling a relatively not so easy question, if you are going to be having the presence of an increase in the levels of IgD, then the risk of development of renal dysfunction is more. And if there is a specific subtype of IgG, that means immunoglobulin 3 subtype is present, then it is associated with higher risk of development of viscosity of the blood, right? That is what you need to be familiar with so far as the multiple myeloma is concerned. Now, having a word or discussion about the platelet disorders. So I should be rather saying bleeding disorders. Bleeding disorders can either be platelet disorders or clotting factor problem. If the patient is going to be having a clotting factor problem, there is usually a history of trauma and there is a presence of a deep tissue bleeding, bleeding in the joints or bleeding in the muscles. If a patient is going to be having a platelet problem, then these patients are going to be having the presence of petechiae purpura. So these are superficial bleeds and there is usually no history of any kind of a trauma. Whenever we are going to be talking about the specific conditions which can be associated or asked in the exam more frequently, we are asked about conditions in which there are going to be qualitative defects in the platelets. One condition can be Bernard-Solier syndrome. This condition is an autosomal recessive condition. There is a problem with the platelet glycoprotein. Which glycoprotein is defective in these patients? The patients are having a problem in glycoprotein 1b. Because glycoprotein 1b is involved in the process of platelet adhesion. So this is what is going to be causing a trouble, that these patients are going to be having a platelet adhesion defect. That's what we need to remember. The reason why the examiners will ask you a question on Bernard-Solier syndrome is primarily because once you look at the peripheral smear of these patients, they will be having giant or big size platelets. That is what you need to remember over here. Whenever we are talking about a condition which is given the name of Wiskott-Aldrich syndrome, hopefully I can just sit back and relax because you know it more than me. You have already had a discussion of the immunodeficiency or a video. So it is an X-linked recessive condition. XP chromosome contains VASP protein, which is going to be mutated over here. And therefore the patients are having a triad. What is a triad? recurrent infections, thrombocytopenia, and the patient is having eczema. So less number of platelets and small size platelets, tiny platelets, are going to be seen in a patient who's going to be suffering from Wiskott-Aldrich syndrome. Whenever we are talking about a condition in which there is going to be physical damage, angiopathic hemolytic anemia. If it involves small vessels, that is microangiopathic. If it involves big vessels, that is macroangiopathic. So microangiopathic hemolytic anemia would be characterized by the condition which is given the name of DIC. And this is in more than 50% of the cases because of some kind of an obstetric problem. Say for example, abruptio placentae. Say for example, amniotic fluid embolism. Say for example, there is a retained placenta or presence of a dead fetus. So these patients having DIC are going to be having thrombohemorrhagic manifestations, and the patients are going to be having thrombocytopenia as well. Peripheral smear, if there is a DIC, may show you presence of fragmented RBCs which are given the name of schistocytes, right? Please remember the fact that when we are talking about another platelet dysfunction, that is going to be given the name of Glanzmann's thrombasthenia. This is because of a problem in glycoprotein 2B3A. So whenever we are talking about a condition that is given the name of Bernard-Solier is glycoprotein 1B problem. And when we are talking about Glanzmann's thrombasthenia, it's a problem of glycoprotein 2B3A. If there is a glycoprotein 2B problem, the patients are going to be having a characteristic history. There is excessive bleeding from the umbilical stump. So that is what we need to remember over here with regards to a platelet aggregation defect that's given the name of Glanzmann's thrombasthenia. Having said that, we just need to have a quick recap about the different findings that we have in case of hemostatic disorders. Of course, I can just quickly then wrap up by talking about certain specific features of some of the disorders. As and when we are talking about a patient having hemophilia A and B, they are classical example of male patients who are going to be having an increase in their APTT. The rest of the findings are going to be normal because there is a clotting factor 8 problem in hemophilia A, clotting factor 9 problem in hemophilia B. So these patients will be having a history of a trauma, and then they will be having the presence of a joint bleeding or muscle bleeding. In contrast, if I'm talking about a condition like von Willebrand disease, it's an autosomal dominant condition in most of the patients. Even though the patients are having a normal platelet count, still they are going to be having the presence of increased bleeding time. The reason simply happens to be the fact because of von Willebrand factor deficiency, the platelets are not able to function normally. Because of the decreased half-life of factor 8 in these patients, APTT is also going to be increased. So von Willebrand disease is characterized by increased value of bleeding time and increased value of APTT. Whenever we are talking about a patient who is going to be having DIC, everything goes for a haywire in a patient having DIC. So platelet count is going to decrease, bleeding time is going to increase, PT is going to increase, APTT is going to increase, and the characteristic finding in the patient is that these patients are going to be having the presence of fibrin degradation products. Just to recap some of the important findings which may be asked as a question in the exam. So far as ITP is concerned, immune thrombocytopenic purpura, if it is an acute condition, that is going to be associated with a pediatric presentation, and the patients are going to be having a more severe kind of a thrombocytopenia. Chronic ITP is what is seen as a problem in case of adults, and chronic ITP is going to be characterized by having an association with certain other conditions about which you have to do more investigation. Say for example, you have to rule out the presence of something like the leukemias like CLL, or you have to investigate the patient for something like SLE. Thankfully, the good point about chronic ITP is the thrombocytopenia is not as severe as you have it in case of acute ITP. That is what you need to remember. Talking about or taking a word about von Willebrand disease, that is what I just wanted to have an idea. It's the most common cause of inheritable cause of bleeding. It is going to be associated with chromosome 12, and the type 1 variant of von Willebrand disease happens to be the most common. It is having autosomal dominant mode of inheritance, and there is going to be actually a reduction in the von Willebrand factor. Whenever we are talking about von Willebrand disease, the confirmatory test can be done with the help of something like an aggregometer, and the finding, as I shared with you earlier, increase in the bleeding time and increase in APTT. One important finding that is to be remembered over here is that in contrast to hemophilia A and hemophilia B, we have a condition that is called as hemophilia C, which is because of factor 11 deficiency. Hemophilia A and B were examples of X-linked recessive conditions, so they were more commonly associated with involvement of boys. Hemophilia C is an example of an autosomal recessive condition, so this is equally seen in case of both boys and girls. Whenever we are talking about the concept of factor inhibitors are actually example of abnormal antibodies which can be seen in case of certain individuals. And one of the commonest reasons why they are going to be seen is because if you are going to be giving clotting factors to a person regularly, then you're giving a clotting factor from outside. It can cause stimulation of the immune system, and that can result in the formation of factor inhibitors. Factor inhibitors are more commonly seen in case of females, as is a usual theory with respect to the autoimmune disorders, and they can also be associated with certain types of malignancies. The problem that we have is that if a person is going to be having clotting factor inhibitors, then it is going to be associated with an increase in the value of APTT. Now, how would you find whether we are having an increase in the value of APTT, which is going to be seen because of factor inhibitors, or is the value of APTT is increased because of hemophilia? So the simplest way of differentiating this would be to perform what is being given the name of a mixing study. You take the blood sample or the plasma of a patient and you mix it with a normal plasma taken from a normal individual. When you mix these two, if there is going to be a correction of APTT. Initially, patient came to you. Why? Because he was having increased APTT. But once you are going to be performing a mixing study and you find that the value of APTT now becomes normal. So that means the individual was having a condition that is given the name of hemophilia. So factor deficiencies, mark my words, clotting factor deficiencies are corrected with mixing studies. But if they remain uncorrected, it is still increased, then that means it is going to be caused because of factor inhibitors. So factor deficiencies are going to get corrected by mixing study. Factor inhibitors, if they are present, they are not corrected by the mixing study. That's an important thing for us to be aware of. Talking then about the concept of thromboelastography. Thromboelastography is an example of a single test which is being done in the emergency surgery, orthopedics, gynecology. Typically, why it is being done? Because we do not want to carry out separate tests to see for the functioning of clotting factors, for platelets, for fibrinolytic pathway. So this is a single test which can give you an idea about the functioning of each of these components. It is an example of a graphical representation wherein different parts are present, and we are having the presence of what is given the name of the phase 1, which is what is called as by the name of R time. We then are having the alpha angle. We then are having the presence of the highest value which is seen over here, maximum amplitude, and after that we are going to be having the activation of the fibrinolytic pathway. The phase 1 is what is going to be dependent upon clotting factors. The alpha angle is going to be dependent upon fibrinogen. The maximum amplitude is dependent on platelet activity. And then you are going to be having the lysis or the fibrinolytic pathway, which is going to be representative of the activation of the fibrinolysis depicted by Ly30. So when we are comparing the 4 components over here, 1, 2, 3 and 4. In a patient having a presence of a platelet problem, the 3rd component is affected. A patient is having hemophilia, the 1st component is affected. A patient is having a problem in fibrinolysis, the 4th component is affected. So these are the important things. And then what we need to remember over here is the different types of patterns which are going to be observed. So normally you are going to be having a pattern which we have just now understood. So we are going to be having the presence of phase 1, then fibrinogen deposition, then a maximum amplitude, and then it is going to be coming down because of fibrinolysis. Any patient who is going to be having the presence of hemophilia, as you can mark out over here, any patient having the presence of hemophilia, there is a clotting factor deficiency. So phase 1 is what is going to get prolonged. Any individual who is going to be having a platelet dysfunction, platelet problem, the maximum amplitude is going to get reduced. If there is an individual who is going to be having the presence of fibrinolysis, too much of fibrinolysis, then of course the last phase is what is going to be becoming in this kind of a fashion. And a disease in which platelets are having a problem, clotting factors are having a problem, fibrinolytic pathway is having a problem, that is called by the name of DIC. So in DIC, patients are going to be having a drop-like pattern of TEG, and that is called as drop of death. In DIC, patients are going to be having a drop of death pattern. That is what we find in case of the thromboelastography. So the reason or the importance of knowing about the test is important. The components are important because individually the questions have been asked on maximum amplitude, the question has been asked on factor phase 1, and we need to be having an idea about the interpretation as well. Then talking about a high yield topic which is going to be with respect to the different types of vacutainers that are being used in the practice. So we are going to be having the sequence or draw the blood sample which is going to be remembered by you. Initially the first sample should be taken, and that is what is to be done for the blood culture. Then we are going to be taking the sample of draw that is going to be in this kind of a fashion from top to down. The blue top vacutainer is going to be containing trisodium citrate. It contains trisodium citrate, and this trisodium citrate is going to be useful for, the vacutainer is useful for carrying out study like the platelet studies and the coagulation study. The coagulation studies include PTA-PTT study. Platelet studies are going to be done with the help of a sample which is platelet-rich plasma. Red top vacutainer is going to be the plain vial, and this one is going to be having the presence of a clot activator. It is having the presence of a clot activator. So if you are having a clot activator, of course, this is going to be facilitating the formation of serum, and therefore all the kind of routine tests that you go in for is going to be done with the help of this kind of a sample. So whenever we wish to carry out something like, let us say, the KFT, the LFT, this is what you are going to be looking at the red top or the plain vial. When you are talking about the yellow one, it is going to be having the presence, or it is going to be done only when you wish to carry out a special investigation like the HLA typing. Talking about the green top vacutainer, that is going to be containing primarily, green one contains heparin. So heparin contains green. That is how you remember it. Heparin in green. And this is what is going to be useful in context of estimation of something like electrolytes. For that matter, something like the estimation of arterial blood gas analysis, even though a lot of times you'll be using that particular syringe which is going to be heparinized. When we are talking about the lavender color tube is going to be containing EDTA, and that is very useful for carrying out the routine procedures, say for example, E star estimation, or what you go in for something like the complete blood count, right? So for that purpose, you are using the lavender color vacutainer. Then we have a gray color vacutainer. The gray color vacutainer contains two chemicals. One is sodium fluoride, and it also contains potassium oxalate. Both the chemicals have got different function. Potassium oxalate, which is present in the gray top vacutainer, actually is the one which is going to be acting as an anticoagulant. And sodium fluoride, which is present over here, is going to be a glycolysis inhibitor. So, two types of questions that you can answer. If you are having a gray top vacutainer, what is the chemical which is present which is going to prevent the clotting of the blood? That is going to be answered as potassium oxalate. And if the gray top vacutainer question is asked and it is asking you which chemical is responsible for proper blood glucose estimation, then your answer is going to be something like sodium fluoride, which is a enolase inhibitor. Remember enolase? It was involved in the glycolytic pathway, so it is going to be inhibiting the metabolism of glucose, right? Whenever we are now talking about the blood transfusion and blood grouping, so we are going to be having a bag that is going to be given the name of Chitra bag, which is going to be having different capacities. It usually is going to be having, the standard bag has 350 ml capacity, and out of the 350 ml, 49 ml or around, close to, you can say for the sake of remembering, out of 350, 50 ml is going to be anticoagulant solution. Bigger bags, which are going to be having a 450 ml capacity, are going to be having 63 ml of anticoagulant solution. Different types of anticoagulant chemicals can be added, and the standard one, which is going to be having practically the maximum half-life, is going to be sagam, saline, adenine, glucose, mannitol. This one is going to be having a shelf life of around 42 days. Of course, exam questions have been asked earlier with respect to other chemicals which contain ACD or CPD, in which the shelf life is going to be 21 days. Or sometimes we are asked question in the exam on CPDA, which is going to be having a shelf life of 35. Practically, but if the question asked in the exam is, we will try to think in terms of the best anticoagulant solution available, that is sagam, and saline, adenine, glucose, mannitol is going to be having a shelf life of 42 days. Whenever we are talking about the different components of blood, that can be including something like the RBCs. So RBCs are best kept at a temperature between 2 to 6 degrees Celsius, and they have a shelf life of 42 days. When we are talking about platelets, platelets have a problem that they have a tendency to settle down and they have a tendency to adhere. So platelets are kept at room temperature, that is fact number 1, and they have to be kept with a machine that is given the name of the agitator. So you have to keep on moving the platelets so that they do not settle down. If you are using an agitator, the half-life or the shelf life of the platelets over here, half-life is a term that is used for drugs actually, shelf life over here happens to be 5 days. If you are not using the agitator, the platelets are having a life which is going to be, shelf life is only 1 day, right? The third component that we need to remember over here is fresh frozen plasma and cryoprecipitate. Both fresh frozen plasma and cryoprecipitate are kept at a frozen temperature, minus 18 degrees Celsius to minus 30 degrees Celsius. Since they are frozen, therefore they are going to be having a long shelf life, and that long shelf life happens to be 1 year. So whole blood and packed RBC 42 days, platelets with agitation 5 days, platelets without agitation 1 day, and fresh frozen plasma and cryoprecipitate is going to be having a shelf life of 1 year. Very rare situation in which, let us say, the patient is having febrile neutropenia, or the patient is going to be having the presence of something like aplastic anemia. You may have to give these patients granulocyte precursors. Granulocyte concentrate. So granulocytes or WBCs, they are going to be again having a shelf life which is around 24 hours. Whenever we are talking about the differentiation between cryoprecipitate and fresh frozen plasma, please remember cryoprecipitate is rich in 4 factors. What are these 4 factors? Von Willebrand factor, factor 8, factor 13 and fibrinogen. So 4 factors are present in the cryoprecipitate, that is, I repeat, factor 1, factor 8, von Willebrand factor and factor 13. As and when we wish to carry out something like the blood transfusion would be done obviously with the help of a blood transfusion set. You would be requiring or having a needle in it, which most of you have seen by yourself, 18 to 19 gauge needle. It also has a filter, so that if there is a small clot which is produced, then that should be removed. The filter is going to be having a size of 170 to 200 microns. So the needle 18 to 19 gauge, and what you are having over here is a filter. The filter is going to be having a size of 170 to 200 microns. Whenever we are going to be talking about the blood transfusion, especially in case of the component like FFP or cryoprecipitate, the point is when you are taking them out from the freezing temperature, you have to immediately transfuse them as early as possible. Otherwise, what you have to remember over here is that once you are taking the whole blood or the packed RBCs out of the blood bank, so that they do not transmit any infections and stuff, you have to ensure that the transfusion should start within 30 minutes after taking them out, and the transfusion should finish maximally by 4 hours. Right? So within 30 minutes and the transfusion should finish by 4 hours. Whereas in case of FFP and cryoprecipitate, you take them out usually, these are life-threatening conditions where you wish to require them for replacement of the clotting factors. So they have to be given at the earliest, right? Whenever we are going to be talking about the platelets now, with respect to the platelets, we need to remember there are 2 types of platelets that we have. One are the random donor platelets and the second are single donor platelets. The random donor platelets are going to be increasing the platelet count by 10,000 per unit of the platelets being transfused. The only problem is that because they have been, multiple people have given them, so there is an increased risk of alloimmunization. Single donor platelets are coming from a single donor. But the important thing that we need to remember over here is that whenever we are going to be taking the platelets from a donor, if anybody of you has for that matter gone in for something like a platelet donation, you are going to be having a procedure that is given the name of platelet apheresis. Platelet apheresis. So they are going to be, kind of taking your blood out. The blood goes into a machine. The machine is going to be removing the platelets and the blood is then given back to you. When the blood re-enters, the blood from which the platelets have been removed, when it is re-entering inside the body of the individual, then it is going to be containing the presence of the molecules or the chelating complexes. The chelating chemicals are going to be responsible for causing decrease in the calcium. So when you are carrying out a procedure of platelet apheresis, there is a development of a transient hypocalcemia. And whenever there is a development of a transient hypocalcemia, the clinical manifestation is quite commonly when people go for platelet donation, they will complain of a perioral tingling or perioral numbness. So because of the presence of the chelating molecules over here, there is a transient hypocalcemia which is going to explain the development of a perioral numbness or perioral tingling sensation. Next, we need to have an idea about a very important topic which is with respect to the complications of blood transfusion. So for the donor, it may include something like maybe, some kind of a pain or bruises, or even if the people are not well hydrated, they can even have an episode of dizziness or syncope, or they can even have a development of a transient hypocalcemia as I explained you, which is usually taken care of with the help of, we have to regulate the rate of infusion, and at times it can be managed simply by giving oral calcium supplementation. So calcium, because it is becoming less, that's causing the hypocalcemia, so that can be managed very well. Otherwise, what is going to be seen with respect to the recipient is the most common blood transfusion reaction happens to be the development of a fever, and that is what is given the name of a febrile non-hemolytic transfusion reaction. Febrile non-hemolytic transfusion reaction. That is typically going to be seen because of the WBCs being given to an individual, and these WBCs are going to be responsible for causing the release of cytokines. Now, if you do not want, theoretically, if you do not want to have a development of this fever, it is usually a mild kind of a fever, easily managed with the help of paracetamol. But if you do not want to have a development of this kind of a fever, what you can go in for is a specialized component of blood that is given the name of leukodepleted blood. Leukodepleted blood. So if I am taking out the white blood cells from the donor blood, then you are not going to be having a chances or development of fever. The other problem which can happen is that because of a clerical error in the blood bank, a wrong sticker is pasted on the blood bag, and that can be responsible for causing a development of a hemolytic transfusion reaction. So mismatched blood transfusion reaction has been reported, and globally, it is going to be seen because of a clerical error, simply because of high workload. A wrong sticker is being pasted, and that is going to be responsible for causing the trouble. Now, what is the clinical manifestation? If the patient happens to be conscious, immediately on starting the transfusion, this patient is going to be having a development of severe pain and high grade fever. Also, if there is going to be hemolysis taking place, it can be responsible for causing clogging of the renal vessels, and that can be responsible for causing flank pain. So, if there is going to be a severe pain complaint by the patient, or if there is going to be a sudden development of high grade fever with chills and rigors, the important thing that you need to remember is that you have to stop the transfusion immediately. Ideally speaking, after stopping the transfusion, you have to maintain the intravenous line, and what has to be done then is that you have to send the remaining blood along with the blood sample of the patient back to the blood bank for the purpose of cross matching. Sometimes it may happen that a patient is posted for surgery. This patient has already been anesthetized, and after anesthetizing a patient, now say for example intraoperatively you have given him blood, and it is an example of a mismatched blood transfusion reaction. So now this patient will not complain of any pain because he is already under the effect of anesthesia. So in case of an anesthetized patient or a comatose patient, what you are going to be observing is oozing of the blood from the different surgical sites, including the site of venipuncture. Oozing of blood in an anesthetized patient or comatose patient is an indicator that we may have given the wrong type of blood to individuals. So protocol remains same. You have to stop the transfusion, you have to maintain and push the normal saline, and you have to send the blood bank along with the sample of the patient back for the purpose of cross-matching. We are asked questions in the exam pertaining to two special complications as well, which are going to be given the name of TRALI, that is transfusion-related acute lung injury. It is specifically seen with a component of the blood that is given the name of fresh frozen plasma. And that occurs within 6 hours of transfusion of the fresh frozen plasma. The reason is that there is going to be formation of antibodies against the white blood cells, and that is going to be responsible for causing the acute lung injury. So, neutrophils are sequestrated in the pulmonary circulation, and they are going to get activated during the development of TRALI. Patients are typically going to be having the development of a non-cardiogenic pulmonary edema in this condition, and they will be having the presence of respiratory distress. The other condition that is not to be missed over here is what is given the name of TACO. When you're talking about TACO, that is transfusion-associated circulatory overload. Transfusion-associated circulatory overload. So that means within a short span of time, you have given multiple units of blood to this patient, because of which it has resulted in volume overload. So the features in these patients are going to be respiratory distress, but they will be resembling just like a cardiogenic pulmonary edema. So there is going to be increase in the JVP, jugular venous pressure, increase in the BP of these patients. That is what you need to remember. So in case of TRALI, the JVP happens to be normal. In case of TACO, the JVP happens to be raised. In case of TRALI, the BP is going to be less, it is reduced. In case of TACO, it is going to be increased. In case of TRALI, it is specifically because of fresh frozen plasma. And in case of TACO, it can be seen only because of short span of time you have history of multiple transfusions being given to the patient. Because TACO is because of fluid overload. So if I take out the fluid, by giving drugs like diuretics, patient is going to be having a very good response. TRALI on the other hand is in a bad condition. Even if you give diuretics, it is not going to be responding. That's obvious. Then we need to be familiar with the concept of what is going to be given the name of the graft versus host disease. Graft versus host disease can be seen because of immunocompetent donor T cells, and this is going to be seen after a gap of around 7 to 10 days. Now, what can be done for decreasing the chances of graft versus host disease? If you are going to be minimizing the immunocompetent donor T cells, and that can be done with the help of irradiated blood. So, irradiated blood is going to be associated with decreased risk of development of transfusion-associated GVHD. Irradiated blood is going to be associated with reduced risk of development of transfusion-associated GVHD. That is what you need to remember. Then comes the concept of infections. Maximum chances of transmission of infections are going to be seen with respect to platelets. The reason is obvious, because platelets are being kept at a room temperature. There can be lots of bacteria which can be transmitted. Say, for example, staph can be transmitted, particularly the staph other than Staph aureus, Pseudomonas. You are seeing an infection. Therefore, what is important for us is practically screening of the blood, and screening is being done for HIV, Screening is being done for hepatitis B. Screening is being done for hepatitis C. It is being done for malaria. But as you may be familiar, friends, it is not being done for something like dengue. It's not being done for something like dengue. We don't do any kind of a screening. No screening is being done. No screening is being done for hepatitis A as well. The other thing that we need to remember is that an infection, particularly an infection like syphilis, is the one which can be transmitted by practically all components of blood. Syphilis is an example of an infection which can be transmitted by practically all components of blood. That is what you need to remember over here. Then we have a word or two about what is going to be given the name of massive blood transfusion. Massive blood transfusion, when you're going to be literally replacing the complete blood volume of an individual within a short span of time, right? And that is what is also going to be associated with complications. One of the complications that you need to remember over here is going to be hypothermia. Hypothermia. So, blood has been taken from the blood bank. It is kept at a temperature which is 2 to 6 degrees Celsius. And you are pumping in massive units of blood that can be responsible for causing hypothermia. There can be other problems which can be seen in case of transfusion. Say, for example, something like hyperkalemia. There could be a development of metabolic alkalosis. And the patients could also be having a development of hypocalcemia. Metabolic alkalosis explained by the fact that there is going to be a conversion of citrate into bicarbonate, and the body will try to retain the H plus ion, so it is going to be rather responsible for causing a development of hypocalcemia, and then there is going to be a potassium disturbance as well, right? Then we are going to be talking about a condition which is going to be given the name of dilutional coagulopathy. Dilutional coagulopathy, which can be responsible for causing death of the patient by causing DIC. Now, this is something which can be prevented. Dilutional coagulopathy can be prevented provided we follow the simple transfusion protocol of 1:1:1. That's important. 1:1:1 means that instead of giving all the whole blood units, what you going to do to these individuals is 1 unit of RBCs, 1 unit of plasma, and 1 unit of platelets. If you do that, you will ensure that all the components are going over here, and therefore it is going to be a protection against the dilutional coagulopathy. Dilutional coagulopathy. That is what we just need to remember over here. Of course, for the sake of just a description and knowledge, we have just added what is going to be given the name of the process of blood transfusion, wherein you are going to be having the order of a doctor. Then the blood is what is going to be prepared. Then cross-matching is what is to be done. So the sequence was once asked in the exam. So you have to look at the doctor's order. You have to see and prepare the blood. You have to do the cross-matching over here. Then the blood has to be ordered. And the blood, once it is going to be getting delivered, then it is subsequently going to be transfused, right? It is better that you are going to be transfusing the blood after checking the blood component completely, and then you may rewarm it with the help of inline warmers if at all necessary. For example, in case of multiple units being given to the patient, and you have to confirm the identity of the patient. Pretty important practically. And then you have to observe the patient till the time the transfusion is absolutely completed. Then we just need to make a mention of something which is going to be given the name of blood grouping. With respect to blood grouping, the questions have been asked in the exam with respect to the rarest blood group. And the rarest blood group, as I believe most of you have an idea, is what is going to be given the name of the Bombay blood group. So when we talk about people who are going to be having blood groups like A, B, O, they usually have the expression of the H antigen. But people who are going to be having a blood group that is given the name of Bombay blood group, they are not having the expression of even the H antigen. The problem therefore that we have in these patients is that in case they require a blood, in case they have a requirement of a blood, the only blood which can be safely given in them is Bombay blood. So usually we use about the fact that people who are going to be having the blood group O, we say that it is an example of a blood which is going to be given to anybody. But people having Bombay blood group cannot be given, and that's what was asked as a question. They cannot be given even blood group O. That is what we need to remember over here, because they are going to be having a transfusion reaction even when they are going to be given blood group O. That is what we need to keep in mind over here. So this is what is going to take care of a discussion of the important features with respect to the questions which have been asked in the exam, particularly from the topic of hematology. Hi friends, so now we talk about the systemic path in which we are going to be now having a discussion about the renal system. The very first thing in the renal system that you are expected to be familiar with is with respect to the urine examination of a patient. Now, when we do a microscopic urine examination of a patient, an important topic which is not to be missed for the exams is going to be the different types of casts that we are going to be seeing in the urine of an individual. Each of these casts may be having a property. Let us just quickly have a recap about them. When we are talking about a cast that is given the name of a hyaline cast, it's the only important example of a physiological cast. You should be aware of the fact that this particular cast is going to be made up of the TAM phosphol protein, and this cast therefore is going to be having the presence of a transparent appearance. What exactly is going to be the source of this cast? That is going to be the cells of the ascending limb of loop of Henle. The amount of protein that is excreted in the urine of a normal individual is typically going to be less than 150 milligrams over a period of 24 hours. We could be having a situation wherein an individual is going to be having proteinuria, or an individual is going to be having the presence of the pathological conditions which can be associated with other different types of casts. For example, if I'm talking about something which is given the name of an RBC cast, this is very much suggestive of the fact that the patient is suffering from glomerulonephritis or nephritic syndrome. We shall be talking about the causes of nephritic syndrome in just a short while from now. As and when we are making a mention of a WBC cast, that is indicative of some kind of an infectious condition. So typically that would be seen in a patient suffering from pyelonephritis. Patients who are going to be having the presence of a condition like diabetes mellitus are at higher risk of suffering from chronic kidney disease. And if the patients are having chronic kidney disease, the casts are going to become big in size and they are going to be having a waxy appearance. So whenever we're talking about a broad waxy cast, this is going to be seen in a patient suffering from chronic kidney disease and diabetes mellitus. Any mention of the term lipid cast in the exam should make you alert of the fact that the examiner is asking a question on a glomerular condition which is given the name of nephrotic syndrome. Whenever we are going to be talking about the lipid cast, they may also be seen in a patient suffering from hypothyroidism. An alternative word that can be given for the lipid cast is that the description of these casts may be given in the form of the presence of, the question can say, oval fat bodies, and this is going to be having a polarized microscopic appearance that is given the name of Maltese cross. Remember the fact Maltese cross is what you also associate apart from nephrotic syndrome in a condition that is given the name of Fabry's disease. So those are the different types of casts that you need to have an idea. Of course, in case of a situation when the patients are going to be having an allergic condition, say for example an interstitial nephritis like condition, they could be having the presence of an eosinophiliuria or an eosinophilic cast as well. These are the different appearances of the cast that we need to have an idea, but the appearances are relatively less important. The names and the associated conditions are far more important from the perspective of the exam questions. Talking now about the glomerular disorders, we shall be dividing them into nephritic syndrome and nephrotic syndrome. The nephritic syndrome conditions, also called by the name of the glomerulonephritis, can be remembered easily with the salient features of them remembered with this particular table. So if I'm talking about the most common cause of nephritic syndrome that we are going to be having in case of the pediatric population, that is to be remembered and answered in the exam as the post-streptococcal glomerulonephritis. Patients typically will be having a history of a sore throat about 2 weeks prior to the development of symptoms over here. And subsequently, they are going to be having a development of a hypertension. They are going to be having the development of a headache, malaise, and the passage of a cola-colored urine. Microscopically, the kidney is going to be showing you the presence of subepithelial humps, and that is attributed to the deposition of the immune complex. If I say immune complex, of course, you are remembering the fact it is an example of a type 3 hypersensitivity reaction. What you're going to be finding in this condition is on the immunofluorescence examination of the kidney tissue, you're going to be having the presence of starry sky appearance. Remember, starry sky appearance that you get in radiology with respect to the cardiac sonography is what you see with amyloidosis. What you talk about starry sky appearance with respect to a condition that is associated with lymph node biopsy would be Burkitt's lymphoma. And here we are talking about kidney tissue being examined, having a starry sky appearance, therefore having post-streptococcal glomerulonephritis. Having a look at the post-streptococcal glomerulonephritis, patients are going to be having the presence of hypercellularity of the glomerular tissue. And this is the characteristic feature that you're going to be observing over here, the presence of a subepithelial hump. So the subepithelial hump is pretty much characteristic over here. Immunofluorescence revealing you that kind of a granular pattern is what I was sharing with you, the example of a starry sky appearance. Having said that, if we are talking about a patient who is going to be having a pre-existing renal disease or some kind of a vasculitic disorder, and then he is going to be having a rapid deterioration in his renal function. That is what is going to be associated with a term rapidly progressive glomerulonephritis. This condition is unfortunately associated with a rapid decline in the kidney function of a patient within a span of few weeks, maybe just about 2 to 3 weeks. Patients are going to be having histological finding that they would be having the presence of a crescent-like structure, and the formation of crescents is going to be attributed to parietal cell proliferation. There is going to be an infiltration caused by the white blood cells, and there is going to be presence of deposition of fibrin. When we talk about RPGN, this can be attributed to 3 subtypes. Type 1 RPGN, which is classically associated with anti-glomerular basement membrane antibodies, conditions like Goodpasture syndrome. Type 2 RPGN is what you associate with immune complex disease, for example, IgA vasculitis, henoxylone purpura, that is what was called as earlier SLE, another condition which can contribute to this, or it can be associated with any subsequent condition which is going to be having immune complex. When you're talking about type 3 RPGN, clinically that is the most common and that is associated with vasculitic disorders, particularly ANCA-associated vasculitic disorders. Type 3 clinically happens to be the most prevalent subtype as well. Any patient who is going to be having the third subtype, which is given the name of Buerger's disease, is going to be an adult patient who is again going to be having a history of a sore throat or a urinary tract infection. And just about within a span of 48 to 72 hours, this individual is going to be having the development of clinical symptoms. Patients can be having multiple episodes of hematuria, and this condition is going to be characterized by the pathogenic antibody, that is IgA antibody, getting deposited in the mesangial area of the kidney. So Buerger's disease is B and D, Buerger's disease, big people's disease, and associated with deposition of IgA antibody in the mesangial area. That's exactly what you're going to be observing on the histological examination as well. And that is so very characteristic of this kind of a disease. Having a look at the important images, when you're talking about Buerger's disease, this is an area which is affected, that is a mesangial area. And the same is something which can be appreciated with respect to the immunofluorescence examination. When we are talking about the condition that is going to be given the name of Alport syndrome, a rare condition, thankfully, but is going to be important because it is going to be causing not only the involvement of the kidney, but patients are also going to be having the involvement of the eyes in the form of development of lenticonus or the corneal defects. Patients are going to be having the involvement of the ear in the form of development of sensory neural hearing loss. The main problem in a patient having Alport syndrome happens to be a defect in a collagen. And this particular collagen, as we understand, is going to be collagen subtype 4. It is the alpha 5 chain which is going to be primarily defective in these patients. Alport syndrome is important because it can be transmitted from one generation to the other by different modes of inheritance, out of which the X-linked dominant mode happens to be the predominant mode of inheritance. Whenever we are talking about a suspected diagnosis of Alport syndrome, it is confirmed with the help of a kidney biopsy tissue, and that is subsequently examined by electron microscopic examination. What we find in the electron microscopic examination is the characteristic basket weave appearance. So that is what is going to be associated with important finding of making a diagnosis of Alport syndrome. Basket weave appearance, wherein you are going to be having the alternative appearance or the altered thickness of the wasted membrane in different areas in the kidney. This particular tissue is what is going to be representative of the presence of a crescent-like structures, primarily because of parietal cell proliferation. And what is the clinical significance? Just a revision. So this is going to be associated with the rapid decline in renal function. Any question that is going to be making a mention of immunofluorescence sometimes is being confused by students. So let us just clarify this, that if you're going to be having the presence of a linear immunofluorescence, that is going to be having the presence of a smooth appearance. And this is going to be associated with a uniform distribution of the immune complexes. This condition is also going to be associated with mainly the deposition of pathogenic antibodies over here. So it is quite characteristically seen in a patient suffering from Goodpasture syndrome. In contrast, if we are going to be having the presence of a granular appearance, that's called as granular immunofluorescence, and this is going to be associated with scattered deposition of immune complexes. Can be seen in multiple conditions, out of which one can be that you're going to be having a patient who's going to be having the presence of membranous glomerulopathy, or can be seen in a patient who's going to be having the presence of, for that matter, the post-streptococcal glomerulonephritis as well. So linear one is going to be smooth, and GBM or glomerular Goodpasture syndrome, anti-GBM antibody disease, is going to be characteristically associated. Having a word about nephrotic syndrome, this can be associated with massive proteinuria, hypoalbuminemia, and the patients are going to be having the presence of lipid casts. When we are talking about nephrotic syndrome, different age groups are going to be having different causes of it. But one common finding that we have over here is extensive damage to the podocyte. So there is effacement of the podocyte, which is best appreciated on electron microscopic examination. If you look at the important causes of nephrotic syndrome, the most common cause that we have in context of children happens to be minimal change disease. Minimal change disease is going to be characterized by the patients are going to be having the presence of findings of nephrotic syndrome, including massive proteinuria, hypoalbuminemia, edema, and the presence of lipiduria. In the light microscopic, we do not have any abnormality that can be detected. So therefore, the name of the condition is minimal change disease. However, the best way to confirm the diagnosis over here is electron microscopic examination, which is going to be showing you the presence of effacement of the podocyte. You do not get any immune complex deposition in a patient having minimal change disease. Any patient having nephrotic syndrome classically can be undergoing serum protein electrophoresis, which will show them that they will be having a decrease in the concentration of albumin. But surprisingly, what the patients are going to be having is that there is increase in the levels of alpha-2 proteins, that is because of attribution of increased levels of fibrinogen. Whenever we are talking about the commonest cause of development of nephrotic syndrome in case of an elderly individual, that is because of membranous glomerulopathy. For most of the individuals, the cause is unknown, so it is idiopathic. However, the idiopathic variant would be associated with a specific type of an antibody that can be seen in the patients, which is called as the phospholipase A2 receptor antibody. Membranous glomerulopathy is also having a strong association with patients having a history of cancers, for example, colon cancer, for example, breast cancer and melanoma. Some patients can be having a history of association with connective tissue disorders as well, like SLE. There may be patients who can be having an association with infections, most commonly usually a hepatitis B infection, or sometimes can be associated with hepatitis C as well. One of the characteristic features that we have in this condition is that there is formation of immune complexes. These immune complexes are responsible for an electron microscopic appearance in these patients, which is going to be associated with the subepithelial deposits. In the silver staining, special staining, they can also be associated with appearance that is given the name of spike and dome pattern. Now, with respect to or in comparison to minimal chain disease, membranous glomerulopathy is a more severe inflammation. So patients are going to be having the presence of a non-selective proteinuria. These patients were first studied in the animal model, and the animal model was given the name of Hayman's nephritic model. This particular condition is going to be treated with the help of more powerful immunosuppressive therapy. So patients would be requiring drugs beyond steroids. A common reason for development of nephrotic syndrome that we have in case of adult individual happens to be what is associated with the term focal segmental glomerulosclerosis. This condition can be seen in patients who are going to be having single kidney, history of hypertension, sickle cell disease, or patients who are going to be having reflux nephropathy. Patients are having involvement of few glomeruli, and there is going to be patchy involvement in such glomeruli. A characteristic association of this condition is going to be with respect to a virus like HIV, in which you are going to be having extensive damage at the level of the glomeruli. So that is associated with the term collapsing glomerulopathy. Patients having FSGS can be having certain variants which are going to be called as the congenital variants or causes of congenital nephrotic syndrome. Making a reference to them, one cause can be Finnish type of nephrotic syndrome that is seen because of a defect in a protein that is given the name of nephrin. May I remind you, nephrin is going to be associated with a problem at the level of the NPHS1 gene. We could be having a condition in which patients are going to be having steroid-resistant nephrotic syndrome, which is seen because of NPHS2 gene problem, which codes for a protein that is given the name of podocin. So that is what we need to remember, the clinical relevance not to be forgotten, common cause of nephrotic syndrome in case of adults. We do have another condition that is given the name of the mesangiocapillary glomerulonephritis. This condition is going to be having an association with infectious conditions like hepatitis C or mixed cryoglobulinemia. Mesangiocapillary glomerulonephritis or MPGN can be characterized by the presence of an electron microscopic appearance that is called as tram track appearance. If we are going to be having a variant, then there are two variants which are present, type 1 and type 2. The type 1 variant is going to be having the deposition in the form of subendothelial immune complex deposits. Type 2 variant is the one which is having intramembranous deposits. The type 2 variants, which is having the presence of intramembranous deposits, is going to be associated with the term dense deposit disease. This particular variant is going to be having the presence of an antibody in patients, which is given the name of C3 nephritic factor. Patients who are going to be having the MPGN are typically going to be having features which are going to be associated with an overlap between nephritic and nephrotic syndrome. Whenever we are talking about systemic causes of nephrotic syndrome, SLE, amyloidosis, diabetes are the common conditions which come to our mind. Out of which, the commonest condition associated with nephrotic syndrome happens to be diabetic nephropathy. Such patients are going to be having over a period of time the development of glomerular dysfunction, and they are going to be having a progression into chronic kidney disease. The initial manifestations in case of diabetic nephropathy would be the thickening of the basement membrane. Then there is going to be a development of nodular glomerulosclerosis, which is a very characteristic lesion of diabetic nephropathy, which is given the name of Kimmelstein-Wilson lesion. Over a period of time, there would be a diffuse glomerulosclerosis that would be seen in the patients, and that would be clinically associated with development of the renal shutdown of the patient. Having a look at the important images. So this is the example of the tram track appearance that has been discussed with respect to MPGN, that is going to be associated with immune complex deposition. patients are going to be having the presence of nodular or deposition in context of the diabetic nephropathy, and that's what is being given the name of the Kimmelstein-Wilson lesion. Having said that, we need to be having an idea about if there is presence of glomerular inflammatory conditions, they are going to be responsible for causing damage to the kidney, and classically the patients are going to be having a decrease in the size of both the kidneys. So bilateral shrunken kidney is going to be a complication or associated as a finding of chronic glomerulonephritis. Such patients are going to be having a deposition of the fibrous tissue and collagen, which can be picked up with the help of Messon's trichrome strain. Another condition about which we need to have an idea is the infectious condition which is given the name of pyelonephritis, which is classically going to be seen in association with ascending tract infection. The organism, of course, that is something that you read in microbiology as well, and that's something that we have discussed, Escherichia coli. Patients who are going to be having tubercular pyelonephritis are going to be having the presence of a hematogenous infection spread. Pyelonephritis would be characterized by WBC infiltration in the interstitial tissue, and there is going to be presence of tubular atrophy that is going to be seen. Because of the tubular atrophy, what you find is that in the lumen, you are going to be having the deposition of a pinkish material, which is going to be making the kidney appear or resemble just like the thyroid. So that is what is associated with the term thyroidization of the kidney. May I remind you of the fact that in case of a patient having pyelonephritis, we are going to be having the presence of a shrunken kidney that can be seen grossly. Both the kidneys are shrunken, but there is going to be asymmetric shrinking of the kidney. Urine examination of patients is going to be having the presence of WBC casts. Another condition which can be attributed to an infectious condition over here can be a condition that is given the name of interstitial nephritis. Interstitial nephritis can be an example of a condition in which the patients are going to be having either an ischemic damage or the patients are going to be having the presence of an allergic kind of a reaction. So quite commonly, it is an example of an allergic reaction, say for example, to patients who have taken certain types of antibiotics like penicillins. So patients are going to be taking or they are having a history of intake of antibiotics, and after about 2 to 3 days, patients are going to be having a complaint of fever. They can be having malaise. They can be having a passage of eosinophils in their urine. This is what you need to remember so far as the interstitial nephritis is concerned. If you are talking about a condition that is given the name of acute tubular necrosis, that is also associated with the term acute kidney injury, that can be attributed to ischemic damage or toxic damage. And ischemic damage is a more common reason for development of acute kidney injury. Patients having acute kidney injury are going to be having the dead or the degenerated cells appearing in their urine. So responsible for a finding that is given the name of the dirty brown muddy cast. As and when we are talking about a condition that is called as renal papillary necrosis, it is seen because of a damage at the level of the renal papilla, and the commonest reason attributed is patients suffering from diabetes. Of course, other conditions which may be causing this is sickle cell anemia. This can be seen because of obstruction at the level of the urinary tract, or this can be seen in a patient who is going to be on intake of certain drugs, say for example the painkillers or the NSAIDs. So analgesic nephropathy can be attributed or is going to be associated with renal papillary necrosis. Talking about the vascular disorders affecting the kidney, we are having two important disorders affecting the kidney. One which is going to be given the name of benign nephrosclerosis, the condition which is going to be associated with the deposition of the plasma proteins within the vessel wall. So a pinkish material that is going to be deposited in the vessel wall, quite commonly associated with aging, that is also associated with diabetes and hypertension patients. Grossly, the patients are going to be having a fibrous irregular appearance of the kidney that's given the name of leather grain kidney. The appearance of the blood vessels as is described is given the name of hyaline arteriolosclerosis. The second type of vascular insult which can be seen over here is patients suffering from malignant hypertension, and they are going to be having the presence of smooth muscle proliferation. So it is associated with the term hyperplastic arteriolosclerosis. When we are talking about the microscopic appearance, patients are going to be having the presence of concentric rings of smooth muscle deposition. So having an appearance that is being described as onion skin appearance, and gross appearance of the kidney would be associated with multiple hemorrhagic spots on the kidney, which is associated with the term flea-bitten kidney. Whenever we are making a mention of flea-bitten kidney, we must remind ourselves that it is not something that is specific for malignant hypertension. It can be seen in patients having vasculitic disorders, can be seen in patients who are going to be having different types of leukemias and lymphomas, and can also be seen in a patient who is going to be suffering from a condition like infective endocarditis. Having now a word about the different types of renal cancers, one of the commonest cancers that is going to be asked in the exam is going to be the renal cell carcinoma. It's commonly associated with exposure to something like tobacco, asbestos exposure, for that matter, sickle cell trait, obese patients, and can be associated with patients who have undergone dialysis for a long duration of time. Clinically, patients having renal cell carcinoma have the commonest presentation in the form of a painless hematuria. They may also be having the presence of a costovertebral mass, and they can be having the presence of a flank pain. Let us just remind ourselves that in case of an elderly male individual, if you are having the presence of a left-sided varicocele, this could be because of renal cell carcinoma. Microscopically, patients are going to be having the presence of adenocarcinoma, which can be having further variants or subtypes, which are asked in our exams. The commonest variant that we understand is what is given the name of clear cell carcinoma. And clear cell carcinoma is classically associated with, at a genetic level, VHL gene mutation. Tumor cells over here are arising from the proximal tubule, and they are going to be having the presence of glycogen or fat in them, which is going to get washed off. Therefore, the term is clear cell. So there is a clear cell variant. Please remember the fact that these patients are going to be having an association with VHL syndrome. Whenever we are making a mention of the second variant, that is called as papillary variant, the papillary variant is going to be associated with, at a genetic level, presence of trisomy 7. And the patients are going to be having the presence of a loss of chromosome Y over here. Y over here is going to be having a loss. Some patients can be having the presence of a MET gene mutation. This type of the kidney cancer may also be seen in patients who are undergoing dialysis for a long duration of time. So dialysis associated cystic disease can have a progression into a cancer, and the type of cancer that will be associated in the patients is going to be papillary subtype. Microscopically, this is an example of a condition where there is going to be papillary growth, obviously with the presence of a fibrovascular core, and sometimes you are going to be having the deposition of calcium in the form of concentric rings. When calcium gets deposited in the form of concentric rings, that is going to be associated with the term that is Semoma bodies. The third variant about which we need to have an idea is given the name of chromophobe renal cell carcinoma, which is associated with P53 gene mutation and is going to be important because it is going to be having a very good prognosis. Patients over here are going to be having the presence of polygonal cells, which are having a characteristic presence of a perinuclear halo. This perinuclear halo is going to be associated with the plant-like appearance or a resinoid appearance of the tumor cells. So clear cell carcinoma has an empty looking area, that's a clear area. Papillary cancers are going to be having a papillary growth like this, so that is a finding. And chromophobe cancer, which is having a good prognosis, is going to be having the presence of a perinuclear halo. Any patient who is going to be having a fourth variant, which is given the name of a collecting duct carcinoma, is going to be having the origin of a cancer from the collecting duct. And the problem with this kind of a cancer is it is a very aggressive cancer. Because it is aggressive, so understandably it is going to be having an association with a poor prognosis. The collecting duct carcinoma is also associated with the term Bellini duct carcinoma. Having a word about that, we then need to be having an idea. Sometimes patients who are going to be having the chromophobe renal cell carcinoma is going to be similar to oncocytoma, which is an example of a benign tumor, and that can be differentiated on the basis of Hales colloidal iron. Talking about now a pediatric renal tumor, which is given the name of Wilms tumor. Obviously, that is going to be seen in the age group of children, classically between 2 to 5 years. Patients are going to be having a clinical presentation in the form of abdominal mass, which is being noticed by either of the parents, usually mother, and is going to be associated with other findings like the presence of hematuria and fever. Reason for development of Wilms tumor would be a problem at the level of genes WT1 and WT2 genes. These genes are present on chromosome 11p. We have a precursor lesion for Wilms tumor that is given the name of nephrogenic risks. There are certain types of genetic associations of Wilms tumor. For example, the Wager syndrome, WAGR syndrome, Wilms tumor, and iridia. There is presence of genitourinary abnormalities and there is presence of mental retardation. Patients could be having the presence of Dennis-Brass syndrome, or they could be having a presence of a condition that is termed as Beckwith-Weidman syndrome. The characteristic feature of Wilms tumor is that microscopically the patients are going to be having blastemal component, epithelial component, and stromal component present together. So 3 components are present together. Therefore, this is an example of a triphasic tumor. If the patients are going to be having at a microscopic level, so this is what is going to be representative of the presence of the blastemal cells. The cells trying to form the presence of a structure like this, epithelial cells. And of course, you're going to be having the presence of intermediate, the stromal cells as well. When we are talking about the presence of P53 gene mutation, this is associated typically with high degree of anaplasia, and that would be associated with poorer prognosis of the patients. We need to be having an idea about nephrolithiasis, very importantly asked as a theory as well as image-based questions. Development of renal stones can be seen in the patients, which is going to be present in the form of episodes of painful hematuria. Patients can be having different subtypes of renal stones, out of which the commonest stone that is going to be observed in the patients is going to be the calcium oxalate stone. This is attributed usually to development of hypercalciuria, for which the cause is not known. So idiopathic hypercalciuria. Patients who are going to be having calcium oxalate stones can be having the presence of calcium oxalate monohydrate stones or calcium oxalate dihydrate stone. Monohydrate stones are the ones which are going to be having an appearance which is going to be a dumbbell appearance, right? So we say mono goes to gym, monohydrate is going to be having a dumbbell appearance. Calcium oxalate dihydrate is the one which is going to be having an envelope shaped crystals present in the urine of the patient. This kind of a stone is more likely to be produced in the acidic pH, and this is going to be clinically the most commonly observed stone. A second stone that we need to associate with alkaline urine, with the presence of infection caused by urea splitting organisms like Proteus, and the one which is going to be having the presence of the three components. Triple stone is the name used, magnesium ammonium phosphate. Magnesium ammonium phosphate is going to be having a standard appearance which is going to be coffin lid appearance. So 23-24, that was a question asked in the IN exam as well, wherein image based question was given over here. The problem with these kind of stones is they are slow growing and therefore they are going to cause massive damage to the kidney. They're also associated with the term staghorn calculus. A third type of stone that we need to have an idea is the uric acid stone. Uric acid stone is again going to be produced in the acidic pH, and this is going to be associated with having an irregular shape or a rosette shape. Uric acid stones have a clinical importance. They cannot be, I repeat that, they cannot be picked up on the X-ray KOV because of the fact that they are going to be radiolucent. Such stones can be seen in patients who are either suffering from gout or a patient who is undergoing cancer chemotherapy. Whenever we are making a mention of the cystine stones are the ones which are classically seen in case of children. And these stones are going to be having a property that they are going to be hexagonal in shape. These are the example of stones which are going to be produced in the acidic urine also. So most of the stones are being produced in the acidic urine with the only important exception of the triple stones or the white stones which are being produced in the alkaline urine. This kind of a stone, cystine stone, happens to be very hard. So it may not fragment when a surgeon is trying to do that with the help of lithotripsy. That's what we need to remember so far as the basic concepts with regards to the nephrolithiasis is concerned. Having a word about a condition affecting the bladder. The condition affecting the bladder can be cystitis, which is going to be seen because of E. coli infection. A second condition that we need to have an idea is given the name of malakoplakia. Malakoplakia is a condition in which there is a defect in the process of phagocytosis. So because of which the macrophages are not able to kill the bacteria properly. Therefore, grossly, the bladder is going to be having the presence of soft yellow plaques and they are going to be having a dirty appearance. So malacomeline, soft plaque means plaque-like appearance. Soft dirty plaques are going to be seen over here. The associated organism over here happens to be infection caused by Escherichia coli or Proteus. And because of the incomplete digestion, we would be having the presence of microscopically the foamy macrophages. Foamy macrophages are going to be given the name of Wann's Henzemann cells. There is going to be deposition of material concretions including iron, including calcium. And when there is going to be iron and calcium being deposited inside the foamy macrophages, that is going to be associated with the term, as you can appreciate it perhaps over here, these are given the name of Michaelis-Guttman bodies. Michaelis-Guttman bodies. So Michaelis-Guttman body simply refers to basophilic inclusions and you're going to be having a deposition of iron and calcium inside the foamy macrophages. The other important condition about which we definitely need to have an idea is urinary bladder cancer. It's a cancer that is going to be seen as a very important cause of development of painless hematuria. We can be having a patient having a painless hematuria, and clinically, if there is a patient coming to your clinic with a painless hematuria, you must think in terms of urinary bladder cancer. There can be different variants of this kind of a cancer. The commonest reason for attributed for this kind of a cancer is tobacco smoke. And the patients are going to be having the cancer even if they are having the presence of a stone for a long duration of time. Can be associated with an infectious cause, that is schistosoma hematobium infection. So patient may be coming from something like a history of being coming from Middle East. And it can be attributed to exposure to certain types of chemicals, particularly aniline dyes. Whenever we are talking about rare causes of urinary bladder cancer, that can be because of a patient having a history of extrophy of the bladder or the presence of an embryological issue that would be persistent urachus. Why is that important? If we are talking about the commonest reason for urinary bladder cancer, that is tobacco exposure. So this is going to be associated with the presence of a transitional cell carcinoma. Patients who are going to be having a history of schistosomiasis infection and the patients who are going to be having stone may be at higher risk of suffering from a squamous subtype of the urinary bladder cancer. History of urachus should alert your mind that the examiner wishes to ask a question on the adenocarcinoma variant with respect to the bladder cancer. Grossly, the bladder cancer is going to be having the presence of a bad looking infiltrative growth over here. That is what you need to remember over here. And whenever we are looking at the microscope examination, you are going to be having the presence of a hyperchromatic cells which are going to be replacing the normal transitional epithelium cells. So they're going to be having a darker appearance. Why is bladder cancer also an important question is that if the cancer is present in a superficial stage, it may be managed in a patient with the help of a drug that is a vaccine as well, which is intravesical BCG. So this is what we need to have a discussion so far as the important concept with regards to the bladder pathology is concerned. Now we talk about systemic path. Next topic that we talk about over here is going to be the respiratory system. And when we talk about respiratory system, just having a quick recap about the important physiological and anatomical fact that the respiratory system is going to be having the functional unit in the form of an acinus, and the acinus is going to be having the presence of alveoli, the respiratory tree being lined by cells which are given the name of pneumocytes. Type 1 pneumocytes, as you may be aware, are going to be more in number, whereas the type 2 pneumocytes are going to be having a function, secretion of surfactant as well as repair function. Why do we need to talk about this basic fact is because we have certain conditions, starting off with something like adult respiratory distress syndrome. The conditions are going to be characterized by the presence of an initial endothelial cell injury, which can be attributed because of multiple reasons. And if there is an endothelial cell injury, there is going to be release of cytokines, which are responsible for causing a damage to both type 1 as well as type 2 pneumocyte. As a result of this, the patients are going to be experiencing a characteristic histological finding, which is going to be diffuse alveolar damage. There is also going to be a deposition of a fibrin lining around the alveoli, because of which diffusion of the gases is not going to take place. As a result of which, what we have in these patients is, if you look at the X-ray of these individuals, they are going to be having an appearance which is going to be given the name of a white out lung. And what we are going to be having over here is that microscopically, they are going to be showing you the presence of a hyaline membrane. So that is something that we unfortunately have seen big time in context of the COVID pneumonia as well, that the patients were having refractory to oxygen therapy. Therefore, oxygen was supposed to be given to them with a high pressure. That was the PEEP way of giving them the oxygen supplementation. A second thing that we need to have an idea over here is going to be given the name of lung abscess. When you talk about lung abscess, it's an example of a condition in which there is going to be a big necrotic cavity formed inside the lungs. Quite commonly because of aspiration of food material. Can be seen at times because of the development of other conditions like a complication of pneumonia, or can be seen because of an extension of a surrounding tissue inflammation. One of the characteristic features that we have in case of a lung abscess is the patients are going to be having a radiological finding wherein they are going to be having the presence of air fluid levels. So this is air and this is fluid, and air fluid levels are going to be seen characteristically in case of a patient who is going to be having a lung abscess. Grossly, the discussion of the pulmonary pathologies can be subdivided into the disorders which are going to be given the name of obstructive disorders and the restrictive disorders, and these are the different parameters and the findings that are commonly asked to you in the exams. Starting off first with the discussion of the obstructive disorders, we have important disorders which are going to be associated with the pulmonary involvement. That would include conditions like asthma. Asthma being an example of more commonly a type 1 hypersensitivity reaction in the patient. As of now, we are making a mention of extrinsic asthma, and therefore patients are going to be having recurrent episodes of breathlessness. They're going to be having wheezing. They are going to be having tightness of the chest, which typically becomes worse at night. We do have the different types of triggers over here. For example, exposure to house dust, or in the Western population, we are having the presence of exposure to population. Intrinsic asthma is an example of a condition where the patients are going to be having exercise-induced asthma, or the asthma is going to be triggered by viral infections, or at times there is going to be a drug-induced asthma. Certain parameters which have been discovered of late, YKL-40 is an example of a protein which is directly going to correlate with the severity of asthma. Of course, we cannot afford to forget about Samter's triad, in which the patients are going to be having the presence of aspirin intolerance. They are going to be having asthma, and they are having the presence of adult nasal polyps. The classical findings of a patient having asthma would include the presence of certain sputum findings, which are theoretical questions usually, but then we need to have an idea about crayola bodies. These are example of degenerated airway epithelial cells. We are having the presence of spiral structure, which are given the name of Kirschmann spirals, or we are going to be having the presence of needle-like crystals, which are going to be derived from the eosinophilic membrane protein that's given the name of Charcot-Leyden crystals. Any patient who's going to be having an asthma is going to be having a histological finding, which is going to be given the name of airway remodeling. This refers to an example of an irreversible change in the airway characterized by the presence of subepithelial fibrosis. There is a presence of goblet cell hyperplasia, and there is going to be presence of smooth muscle hypertrophy, not to forget, of course, the eosinophilic infiltration. Whenever we are making a mention of the second condition, which is going to be one of the components of COPD, that is given the name of emphysema. This condition is characterized by a damage at the level of the acinus, most commonly attributed to cigarette smoking. Nowadays also being seen in increased frequency because exposure to bad air quality, and can be seen in case of coal miners as well. We have a rare variant of emphysema, which is going to be given the name of pan-acinar emphysema, which is attributed to an autosomal recessive condition, alpha-1 antitrypsin deficiency. The more common clinical variant, which is the centri-acinar emphysema, classically is going to cause involvement of upper lobes of the lung, and there is involvement of the proximal part of the SNS. In case of paranasal emphysema, we find that there is predominant involvement of the base of the lung. Patients having paranasal emphysema, apart from pulmonary involvement, are also having hepatic involvement in the form of development of micronodular cirrhosis. These patients classically are going to be having the presence of a dyspnea. They are having weight loss. They are having the presence of a barrel chest. They're going to be having the presence of a pursed lip breathing. And in spite of a condition, they are going to be maintaining their oxygen levels quite comfortably till the very last. Therefore, they are associated with the term pink puffers. What you have over here is abnormal dilatation or the destruction that you are going to be associating with the damage at the level of the SNS. The other condition about which we need to have an idea, which is a part of COPD, is chronic bronchitis. Chronic bronchitis patients are also being given the name of blue bloaters. These are the patients who are having a clinical definition, that is presence of productive cough for a duration of at least 3 months in 2 consecutive years. The most important reason happens to be the presence of cigarette smoking in these individuals, which is going to exacerbate episodes of acute airway inflammation. Patients are going to be having the presence of cough with sputum along with dyspnea, and they are going to be having high risk for development of a cyanosis-like manifestation, therefore the term blue bloaters. Because of hypoxemia, one thing which is going to be more commonly observed in these patients is polycythemia. And the other thing which is going to be observed as a long-term complication is that these patients are always at high risk for development of pulmonary hypertension, which can be responsible for causing mortality. Patients having chronic bronchitis are going to be having increase in the mucus secreting glands, and this is going to be associated with an increase in the value of an index, which is going to be given the name of Reed's index. One of the complications that we have in case of chronic bronchitis patients is that they can be having a development of squamous metaplasia. Remember, we talked about metaplasia in our general discussion. If it is being controlled in the early stages, it is reversible. If you do not control the etiological factor, it can progress into dysplasia and it can further progress to a cancer as well. So that is what we need to remember over here. Having a look at what exactly is meant by the term Reed's index, there is an increase in the thickness of the mucous gland layer. With respect to the thickness of the complete airway wall, this is going to be increased, and that's going to be associated with the term Reed's index. When we are talking about a condition in which we are going to be having repeated infections or obstructions responsible for causing permanent dilatation of the airways, this is given the name of bronchiectasis. Patients having bronchiectasis are going to be having airways which can be traced to the surface of the lung, and this is going to be associated with multiple risk factors. For example, there could be association with genetic conditions like Carter-Jenner syndrome. Patients could be having the presence of cystic fibrosis. Patients who are going to be having some kind of a tumor, or there is an aspiration of a foreign body, or can be attributed to conditions like allergic bronchopulmonary aspergillosis. Clinically, there is going to be presence of dilatation and destruction of the airways, and the patients are therefore going to be having a presence of a chronic cough. A very characteristic feature, this cough is going to be associated with lots and lots, copious amounts of sputum being expectorated by the patient, especially early in the morning with a change in the posture. Quite commonly, patients can be having a presence of a fever, and they can be having a development of the clubbing of their fingers. Some of the patients who are going to be having bronchiectasis can be having a complication, that is in the form of development of a secondary amyloidosis. The diagnosis of bronchiectasis is pretty much clear so far as the gross appearance is concerned, but clinically diagnosis is going to be made with the help of high resolution CT scan. What you're going to be getting in the high resolution CT scan is the patients are going to be having the presence of a tram track appearance, or they are going to be having an appearance that is being described by the name of the signet ring appearance. So signet ring vacuoles is what we talk about generally in context of the mucinous cancers, say for example the gastric adenocarcinoma, or for that matter the Krukenberg's tumor in case of ovary. But when you're talking about the signet ring appearance in context of radiological appearance over here, this is going to be seen as a feature of bronchiectasis. Having a word now about the restrictive lung disorders, we have conditions which are going to be given the name of the usual interstitial pneumonia, which is a histological finding that you associate in a patient suffering from a condition called as idiopathic pulmonary fibrosis. In the pathogenesis of this condition, you have a very important role that is being played by a fibrogenic cytokine that is given the name of TGF-beta. So it is responsible for causing alveolar tissue inflammation, alveolitis, and a deposition of fibrous tissue. These patients are going to be having the presence of irregular dilatation of the airway, and there is interstitial fibrosis. So the term used is usual interstitial pneumonia. A second one which has been asked in the exam just once happens to be a condition which is given the name of cryptogenic organizing pneumonia. This is a condition which is characterized by a histological finding that there will be balls of loose connective tissue, which are going to be present in the alveolar space. And such balls of connective tissue are going to be given the name of Masson's body. So Masson's body are a finding of cryptogenic organizing pneumonia. Then we need to talk about example of a condition in which the patients are going to be having the development of pulmonary hypertension. This can be an example of a primary condition. That means a genetic cause is associated, and the important gene which is associated in these patients happens to be the problem in a gene called as the bone morphogenic protein receptor gene. This is associated with increased deposition of the fibrous tissue over here. Secondary causes can be patients who are going to be suffering from conditions like COPD, as I just now mentioned earlier. One of the characteristic features that you have in these patients is that there is going to be smooth muscle hypertrophy and there is a thickening of the intima. Smooth muscle hypertrophy and thickening of the intima, because of which a term that is being quite frequently asked in the exams, plexiform lesions. Microscope finding over here in these patients is given the name of plexiform lesions. So the gene is important, the name of the lesion is what is important. And why that is important is because the patients are at high risk of suffering from right-sided cardiac failure, which is going to be given the name of cor pulmonale. Anytime we are making a mention of a condition like pneumoconiosis, pneumoconiosis is going to be an example of a occupational problem that is seen because of inhalation of dust particles in the size between 1 to 5 microns. The commonest example of a pneumoconiotic disorder that is seen in the patient happens to be silicosis. And this is going to be seen particularly in people who are going to be involved in some kind of a stone grinding or some kind of a mining or sand blasting. Patients are going to be having predominantly an involvement of upper lobes of the lung. And these patients are going to be having an X-ray finding which is termed as eggshell calcification. Patients have been having another important radiological finding that is going to be associated with the term crazy pavement appearance. So crazy pavement appearance is what I can always add over here with respect to the findings in a patient who is going to be suffering from silicosis. A special finding that we have in case of silicosis patients is the presence of birefringent silica crystals which can be seen on the polarized microscopy. If you are talking about the other important example of pneumoconiotic disorders, the common one asked in the exam happens to be anthracosis, which is seen because of inhalation of coal dust. As a result of inhalation of the black coal dust, the lung are going to become black in color and therefore they would be associated with the term black lung. These patients are going to be having a complication that over a period of time, they can have a development of progressive massive fibrosis. Any patient having the presence of coal workers pneumoconiosis and coexistence with a condition like rheumatoid arthritis is being termed as suffering from Kaplan syndrome. Eggshell calcification is what you can see on the screen, having the presence of those lymph nodes, and the black colored lung is what you see in case of patients who are going to be having anthracosis. One of the most dangerous dust particles about which we need to have an idea is asbestosis. Asbestosis has got a property that it is responsible for causing involvement of base of the lung. Such patients are always at high risk for suffering from multiple types of pulmonary pathologies. The commonest happens to be the development of a pleural plaque. They can also be having the presence of interstitial fibrosis, in which the patients are going to be having the presence of the dumbbell-shaped crystals over here, which are given the name of the asbestos body. Patients having asbestosis are also at high risk of suffering from certain types of cancers. One of the commonest cancers that is going to be seen in these patients happens to be bronchogenic carcinoma. However, read the question carefully. If they are asking you about a history of long-standing asbestosis, say for example 20 years or something, and they ask you the specific cancer associated with asbestos exposure, this is to be answered in the exam as mesothelioma. So commonest is bronchogenic carcinoma, whereas the specific variant is, or the subtype that you need to remember over here is mesothelioma. Different subtypes of asbestos particles are present, out of which we need to remember the serpentine particles of asbestos are going to be less pathogenic, whereas the amphibole particles of asbestos are going to be much more pathogenic in nature. The moment we are thinking in terms of something like infectious lung diseases, an important condition which comes to our mind is typical pneumonia, also called as air-space pneumonia. This condition is characterized by classically infection caused by microorganisms, which are bacteria, and these bacteria are going to be having the presence of the alveolar exudate. The alveolar exudate is going to be quite commonly accompanied by infiltration of neutrophils as well as the presence of fluid inside the alveoli, and this is something which can be appreciated microscopically as well. Such patients clinically present in the form of development of high-grade fever. They would be having the presence of cuffed sputum. They can be having difficulty in breathing as well, and a lot of these patients are going to be having associated pleural inflammation in the form of pleuritis or pleural effusion. Whenever we are making a mention of the second type of pneumonia, which is called as atypical pneumonia, atypical pneumonia is an example of a condition in which the patients are going to be having not the presence of alveolar edema. Rather, they are having the infection caused by different types of bacteria, at times the presence of viruses, fungi, right? And they are going to be having the presence of interstitial tissue involvement. Now, interstitial tissue involvement is going to be associated with not neutrophilic infiltration, but there is going to be associated with mononuclear cell infiltration. Because there is no alveolar exudate over here, so patients are going to be having the presence of a dry cough. They would be having the presence of dyspnea for sure, but they are having the presence of a low-grade fever. So overall, even though the patient is having an atypical or interstitial pneumonia, still the patient is not in a very bad state, and therefore it is also going to be associated with the name of walking pneumonia. Presence of fatigue, presence of malaise is more typically associated with the patient who's going to be having interstitial pneumonia. And this is exactly what we have talked about in the main video section as well. Alveoli are not involved over here, no exudate over here. But definitely what you find is the interstitial tissue, the walls are going to be having infiltration caused by the mononuclear cells over here. Different types of organisms which are going to be having special properties that we just need to have an idea with respect to the different causes of the airspace pneumonia or the atypical pneumonia that we need to be aware of. Having said that, we need to have an idea about one of the common reasons for development of an infectious pulmonary pathologies in our country, that happens to be tuberculosis. If we are talking about the mode of transmission of tuberculosis, that happens to be because of droplet infection. Patients are going to be having the primary tuberculosis who are going to be having the formation of a focus that is given the name of Gons focus. If you have a subpleural lesion, that is what you can see in the gross image over here as well, and we take into account the draining lymphatics as well as the lymph nodes, then this is going to be associated with the term the Gons complex. If there is going to be a calcification of the Gons complex, we are going to be using a term over here that is called as Ranke's complex, which can be seen on the X-ray. Usually, a lot of patients or individuals who are going to be having exposure to mycobacteria are going to be having a development of inactivation of the mycobacteria in due course. However, due to a reinfection or more commonly due to immunosuppression, transient immunosuppression maybe, there is going to be reactivation of the bacteria. And if there is a reactivation of the bacilli, this is going to be responsible as the most common reason for secondary pulmonary tuberculosis. So it is not a reinfection. I repeat that, it is not a reinfection. It is the reactivation of a latent infection which is going to contribute to secondary pulmonary tuberculosis. Now the patients can be having the development of similar manifestations, fever, malaise, but quite commonly secondary pulmonary tuberculosis is going to be associated with a finding that is going to be cavity formation. Why? Because the immune system is already sensitized. How exactly are we going to be having the manifestation of tuberculosis with regards to the sputum examination done with the help of the ZN staining? We will be having demonstration of plenty of acid-fast bacilli over here because of the involvement of the mycolic acid. One special subtype of tuberculosis that we are supposed to remember is miliary tuberculosis, that is more commonly or more likely to be seen in case of individuals who are having an immunosuppression. Such individuals are going to be having the presence of an inflammation. They would be having the presence of involvement of multiple foci in case of the affected organs. So that is going to be associated at times with the term millet-like appearance. Tuberculosis is going to be characterized by the type of necrosis that is going to be caseous necrosis, and patients are going to be having granulomatous inflammation. Of course, we are having the presence of the granuloma formation over here along with the presence of the giant cells. So we are going to be having a collar of lymphocytes surrounding a central collection of macrophages. That's a characteristic feature of a caseating granuloma. Remember the fact, what were the cytokines involved over here? We had in the pathogenesis the role played by the helper T cell subtype in case of tubercular infection, helper T cell subtype 1 or 2. That is what I want to remember, helper T cell subtype 1. There is going to be secretion of interleukin 2. There is a secretion of interleukin 12, and a very important role for macrophage activation is being played by interferon gamma. As and when we are making a mention of confirmatory diagnosis, that is usually done with the help of nowadays the availability of better techniques like the nucleic acid amplification test. That's what we need to remember so far as the concept of tuberculosis is concerned. Of course, I must add over here that if a patient is going to be having the disseminated form of tuberculosis, then you can have multiple types of lesions affecting different organs in the body. So certain terms that you may be, referring to, flectennular conjunctivitis in the eye, or you are referring to something like a patient who's going to be having a sterile pyuria, or a patient who's going to be having a development of a hematogenous pyelonephritis, they're going to be associated with tuberculosis. Then we are going to be talking about the concept of lung tumors. With respect to lung tumors, of course, one of the important risk factors that we need to have an idea happens to be smoking. Lung tumors can also be seen more frequently in patients because of certain types of genetic factors. What you need to remember is patients are going to be having the presence of cough, they will be having presence of weight loss, they will be having hemoptysis, or they can be having presentation in the form of conditions like the paraneoplastic syndromes as well. Some patients who are going to be having lung tumors may be having the presentation in the form of involvement of certain anatomical structures. Say, for example, the autonomic nervous system may be involved, and that can be attributed to the development of a manifestation like Horner syndrome. More commonly, the question in the exam these days would be asking us about the specific properties of the different microscopic or histological subtypes of lung cancer. The important properties that we need to remember over here is with regards to squamous cell carcinoma. It's an example of a cancer of the lung which is associated with history of smoking. Classically, the cancer is going to be having a central location, and these patients are going to be having the development of hypercalcemia as a paraneoplastic syndrome. Quite commonly, these patients are going to be having the presence of a complication like cavity formation. And at a microscopic level, we must be remembering that this cancer is something which can be picked up with the help of presence of keratin. And the IHC markers that we are having over here include P40 and P63. So if you're going to be looking at this kind of an image, which is going to be easy for us to understand, we are quite easily able to appreciate the presence of keratin deposition over here. Sometimes two adjacent cells can be having the presence of keratin as well. And that is what is going to be responsible for usage of the word keratin bridges. So intercellular keratin bridges or deposition of keratin pearls is what you associate with squamous cell carcinoma. The second one that we need to have an idea is going to be given the name of small cell carcinoma. Small cell carcinoma is again going to be having a strong association with smoking. It is also central in location, but clinically it is important because it is going to be having a very poor prognosis. It's a highly aggressive cancer. And this cancer is going to be having a neuroendocrine origin. The cancer is going to be characterized by the fact that tumor cells are going to be responsive to chemotherapy as well as radiotherapy. But because of its small size and aggressive nature, usually when the patient is diagnosed with the cancer, it has already spread to other parts of the body. Typically, it has a high propensity to cause CNS metastasis. The cancer is going to be associated with the electron microscopic finding of demonstration of neurosecretory granules. Tumor cells over here have a rapid rate of growth. Therefore, the chromatin from the tumor cells are going to get released, and this is responsible for having an attachment with the vascular endothelial cells. Therefore, the vascular endothelial cells are going to be having a bluish color, and that's what is being given the name of Azopardi effect. When we are talking about Azopardi effect, easy for us to appreciate, tumor cells are going to be responsible for the release of chromatin material that stains the wall of the vessel. That's what is going to be associated with the term Azopardi effect. The moment we are thinking in terms of IHC markers associated with the small cell cancer, we need to be remembering about the markers like chromogranin. We need to remember about a marker like synaptophysin, and we need to be familiar with a marker that is going to be CD56. Of course, atypically, patients can be having an expression of BCL2 as well. Remember an example of a neuroendocrine marker which is going to be associated with nuclear presence or nuclear staining. Yes, you remember that, right? That was associated with INSM1. If you are talking about adenocarcinoma, clinically very, very important. Why I say very, very important? Because this happens to be the number one cancer that we have globally as well as in our country. This cancer has a precursor lesion in the form of development of what is given the name of adenocarcinoma in situ. And adenocarcinoma in situ is important because it has the term in situ. So it does not penetrate the basement membrane, but it has got an important property. It is associated with erogenous spread. The moment we are thinking in terms of a tumor which is going to be adenocarcinoma, adenocarcinoma is going to be associated with a finding. It is going to be having a peripheral location. Classically described, it was more commonly seen in case of non-smokers as well as in case of females. But this particular cancer is going to be characterized by the fact that there is adeno word over here. So there is presence of mucin secreting glands. As a result of which, patients are going to be having classical paraneoplastic syndromes in the form of migratory thrombophlebitis. They can be having the presence of clubbing as well. Patients having adenocarcinoma are going to be having the appearance of the tumor cells in the form of a glandular pattern. So tumor cells arrange themselves in a glandular pattern. That is what we need to remember over here. What you also need to remember over here is the specific IHC markers which have been asked in the INA-CT exam 2023 as well. And these markers include thyroid transcription factor 1, napsin A, and we are going to be having a marker that is going to be given the name of SPA. Surfactant protein A1 is what is going to be associated over here. So A for adenocarcinoma, the markers which are going to be having alphabet A or the numerical 1, that is what you need to remember over here. Sometimes they may be having an expression of CA as well. More commonly asked in the exam is PTF, napsin as the markers for adenocarcinoma. In fact, that particular image was showing you the presence of the thyroid transcription factor with the brown color, which was associated with the immunostaining and the presence. When we are talking about the large cell variant is going to be a diagnosis of exclusion. Why? Because you do not have any keratin to suggest a squamous cell differentiation. There is no glandular pattern to suggest the presence of adenocarcinoma. There is no presence of a neurosecretory granule. So this is something which is going to be a diagnosis of exclusion. Why is it important is the large cell variant is going to be having an association with the secretion of estrogen-like marker, and therefore the patients are going to be having the presence of gynecomastia as a paraneoplastic syndrome. Attributed along with the bronchogenic carcinoma, we need to have an idea about mesothelioma. This is an example of a lung tumor which is going to be associated with history of asbestos exposure. Patients are quite commonly going to be having the involvement of the pleural tissue as well, whether that is in the form of a pleural effusion, whether that is in the form of a pleural thickening, or whether that is in the form of development of a tumor is mesothelioma. Mesotheliomas are going to be characterized by different types of markers, and the markers that we are going to be having for mesothelioma include a marker like calcitonin. We have a marker that is going to be given the name of D240. We have a marker that is going to be cytokeratin and a marker like mesothelin. So calcitonin, D240 is what I would strongly recommend you to be familiar with, apart from a marker like WT1. So my personal recommendations would be calcitonin, WT1, D240, and why I'm not stressing on mesothelin is because mesothelioma is something that is going to be easily decoded by you in the exam. The other thing that we need to remember is asbestos exposure can be responsible for causing either the development of adenocarcinoma of the lung, or it can be responsible for the development of malignant mesothelioma. The differentiation can be done on the basis of two things. One can be IHC markers, of course. So adenocarcinoma would be having the presence of napsin A, thyroid transcription factor, and surfactant protein. And malignant mesothelioma is going to be having markers like D240, WT1, and calcitonin. The other thing which can be useful for differentiation is electron microscopic examination. In case of adenocarcinoma, you are having the presence of smaller non-branching microvilli on the tumor cells. Adenocarcinoma has the presence of smaller non-branching microvilli. In context of mesothelioma, you are having the presence of slender, long branching microvilli which can be seen over here. So that is what is useful for differentiation for the adenocarcinoma as well as the mesothelioma with respect to the electron microscopic examination, and as I made a mention, likely to be asked only in a tertiary care institute exam. So that's about our discussion of the disorders affecting the pulmonary system. Next topic in systemic path about which you need to have an idea is the gastrointestinal system, and the gastrointestinal system discussion is going to be starting off with the discussion of first the congenital disorders. Now, two important examples of congenital disorders which have been asked in the exams. If we just have a look at the questions, when we talk about the rule of two associated pathology, we need to be reminded of Meckel's diverticulum. It's an example of a true diverticulum which is going to be associated with the fact that it is going to be seen twice more common in case of males in comparison to females. It is 2 inches in length, 2 feet proximal to the ileocecal valve, and is going to be associated with presence of two types of mucosal tissues. One, the gastric mucosa, and the second one happens to be pancreatic mucosa. The second important example of a congenital disorder that we need to have an idea is Hirschsprung disease, which is characterized by the fact that there is an embryonic problem, failure of migration of the neural crest cells. This can be associated with the presence of red gene mutation, and characteristically, histologically, would be having the presence of absence of the ganglionic cells in the submucosal layer. This is also associated with hypertrophy of the cells in the muscle layer, and therefore, radiologically would be having a sign that there is a proximal dilated part of the gut, and there is going to be a distal part which is going to be pretty much constricted. So that's what is going to be seen as a feature of Hirschsprung's disease. Having a look at now the esophageal disorders, an example of a condition where you expect to have the presence of a red velvety mucosa on the endoscopic examination is given the name of Barrett's esophagus. Barrett's esophagus is going to be seen in patients having chronic gastroesophageal reflux disease, and these patients are going to be having a replacement of the stratified squamous epithelium by the intestinal columnar cells. So Barrett's exemplifies an example of the intestinal columnar metaplasia. Intestinal columnar metaplasia is identified on the basis of cells which are going to be having the presence of goblet cells, and goblet cells contain mucin which can be stained with the help of special stain like Alcian blue. So any question in the exam which makes a mention of these three findings, chronic GERD or endoscopic finding of red velvety mucosa, or making a mention of Alcian blue staining for detection of goblet cells, is suggestive of a condition like Barrett's esophagus. One-liners about with respect to herpetic esophagitis, an example of a condition which is characterized by punched out linear ulcers, and of course you're going to be having the presence of ground glass nuclei over here and the presence of multinuclear giant cells. The third condition about which you need to have an idea, immunosuppressed individuals are at high risk of suffering from CMV esophagitis, and CMV is an example of an infection which is going to be characterized by a typical appearance that is associated with the presence of the term owl eye appearance. So owl eye appearance is what you also have discussed in association with Reed-Sternberg cells. Over here we are also having the owl eye appearance. The difference is that since it is a viral infection, you would be expected to have the presence of the intracytoplasmic intranuclear inclusions in context of this kind of an infection. Next, we need to have an idea about the conditions which are going to be the achalasia cardia, which is an example of a motility disorder. And this condition is going to be characterized by a selective loss of the inhibitory neurons. The condition can be either idiopathic or it can be secondary to an infection like the varicella zoster virus, or for that matter, even Chagas disease. This condition is characterized by three important findings. Patients are going to be having increase in the tone of the lower esophageal sphincter. There is going to be absence of peristalsis, and there is going to be incomplete lower esophageal sphincter relaxation, because of which patients characteristically are going to be having dysphagia, which is more commonly observed for the liquids in comparison to the solid food. And over a period of time, if it is present, it is associated with a higher risk of development of squamous cell carcinoma of the esophagus. One of the complications which may be seen in these patients because of the constriction can be that the food material can come back, and that can result in a complication like aspiration pneumonia. Esophageal carcinoma, which is more commonly going to involve the lower 1/3 in the Western countries, is going to be different in Southeast Asia or in India because it is going to be causing an involvement of middle 1/3 of the esophagus. Smoking, presence of or intake of alcohol, presence of nitrosamines intake, Plummer-Vinson syndrome, GERD, and nutritional deficiencies remain the top causes. Right? When we talk about the esophageal carcinoma, patients, in contrast to achalasia cardia over here, are going to be having a dysphagia which is more prominent for the solid food. Reduction in the proper swallowing is going to be associated with less food intake, and that can explain the development of weight loss. Extension of the cancer causing involvement of the nerve can be associated with findings like hoarseness of the voice. Patients are advised to therefore undergo the investigation, which is going to be endoscopic biopsy. And if you're going to be having the presence of a squamous cell carcinoma, of course, that is going to be associated with the presence of keratin pulse. Barium swallow may be showing you the presence of rat tail filling defect. This is absolutely in contrast to the barium swallow appearance that you have in case of achalasia cardia. In achalasia cardia, the barium swallow finding is that of bird beak appearance, and the investigation of choice in context of achalasia cardia happened to be manometry. Whenever we are talking about the condition which is going to be associated with the congenital hyperkeratosis, that is associated with increased risk of esophageal carcinoma, this condition is going to be given the name of tylosis et palmaris. So these are the certain important findings that we need to have an idea. Therefore, you're going to be having the presence of a rat tail filling defect over here. What you're observing over here is the presence of keratin over here. And if you're going to be having the presence of a glandular differentiation, cells are arranging themselves in a gland-like fashion, then that is what is going to be seen as a finding of adenocarcinoma. Having now a discussion about the stomach disorders, one of the commonest disorders that we have in the stomach is gastritis. The type B gastritis is going to be the number one reason for gastritis, and the reason over here is the patients are going to be having an infection caused by a bacteria that is going to be Helicobacter pylori. In the second condition about which we need to have an idea, which is going to be given the name of Meniere's disease, a condition which is going to be characterized by prominent gastric rugal folds. Why are we having the presence of prominent gastric rugal folds? Is because of oversecretion of a cytokine that's given the name of TGF-beta. Such patients can be having the presence of a diarrhea. They can be having the presence of an abdominal pain as well. In a patient who's going to be having the development of the foveolar hyperplasia, you are going to be having the presence of increased risk for development of the carcinoma as well. So why should we be familiar with an example of a condition? Is because of the fact that this condition is going to be having prominent gastric rugal fold, Meniere's disease. It's also associated with a high risk for development of cancer. If the patient would have been having something like a gastritis, of course, it is followed by inflammatory response. And typically, you would be having the presence of neutrophilic infiltration in the lamina propria. You would be having the presence of subepithelial plasma cells. Having said that, we need to be familiar. If you're talking about type A gastritis, that would be associated with an autoimmune etiology. And those patients would be typically associated with having a condition like pernicious anemia. Let's have a word about gastric carcinoma, in which you are going to be having different types of risk factors. And if we talk about primarily the Lawrence classification, we are going to be having the cancer cells arranging themselves in an intestinal fashion wherein there is going to be formation of a gland-like structure, or the cancer could be present in case of a diffuse subtype variant which is associated with E-cadherin gene mutation. Remember E-cadherin, what we talked about in neoplasia as well, associated with not only the diffuse subtype of gastric carcinoma, it's also associated with lobular subtype of breast cancer. Such patients are known to be having the presence of a signet ring appearance. The other way of classification can be depending upon the extent or depth of the cancer involvement. We could be having what is given the name of an early gastric cancer, which is going to be associated with involvement of the superficial layers like mucosa and submucosa. Or we could be having a situation where the patient is going to be having a late gastric carcinoma, which can go deep into the muscle layer or even deeper into the serosa. Whenever we are talking about the presence of a diffuse variant, this may be grossly associated with presence of an appearance of the stomach that is being described by the books as linitis plastica or leather bottle appearance of the stomach. Apart from gastric adenocarcinoma, we do have another important tumor which has been asked in the exam of late. That's given the name of a moltoma, and the moltoma is an example of a B-cell tumor that's going to be seen because of H. pylori infection. Such patients are known to be having the presence of lymphoepithelial lesions, and that is associated with infiltration of the lymphocytes within the gastric wall. Just having a look at some of the important facts, H. pylori is going to be detected with the help of silver staining. I may help you recall. Warthin stari is the one that you're going to be using over here. Right? If you're going to be talking about gastric adenocarcinoma, it is going to be having the presence of those glandular patterns as I discussed earlier. And this particular image would be reminding you of that of the prominent gastric duval folds associated with many triads disease. Having said that, we need to be familiar with the mesenchymal tumor that is present in the stomach, which is given the name of GIST. GIST is going to be an example of a tumor which is arising from the cells of Kajal. This is a tumor which is going to be having the presence of increased tyrosine kinase activity. And because it is a mesenchymal tumor, so clinical presentation of the patient is in the form of gastric bleeding. At a genetic level, this is a tumor that is associated with certain types of markers, for example, c-KIT, for example, succinate dehydrogenase, and a marker like platelet-derived growth factor. Microscopically, the tumor is characterized by the presence of spindle cells as well as we are going to be having the epithelial component. If you look at the IHC markers in context of GIST, the most specific and the best marker happens to be DOG1. And the other ones that we are having is expression of c-KIT as well as CD34. Having a word about the important intestinal infections. Intestinal tuberculosis is quite commonly seen because of either Mycobacterium bovis. Typically, when the person is having a history of intake of pasteurized or raw milk, non-pasteurized or raw milk, it can more commonly be seen in case of something like secondary to pulmonary tuberculosis. So I must add over here that this can be an important reason. So one can be bovis and the second can be tuberculosis. Usually what we find is that if you're having a consumption of pasteurized milk, as is going to be seen in the cities, and the more common reason for development happens to be something like Mycobacterium tuberculosis infection. Patients typically are going to be having the presence of a transverse ulcer, and the part of the gut affected in these patients happens to be the ileum. Why should we be familiar with tubercular infection is because this can result in too much of fibrosis, and that fibrosis can be responsible for causing stricture formation. Clinically, stricture formation is one of the important reasons for development of SAIO, that is subacute intestinal obstruction. If we are talking about enteric fever or typhoid or enteric fever is going to be associated with the intake of a bacteria like Salmonella typhi. We have a fecal mode of transmission of this bacteria, and there is association of involvement of the Peyer's patches in the ileum. If you look at the gross appearance of the ulcer over here, this is going to be an example of a longitudinal ulcer. And at a microscopic level, it shows a very typical finding, presence of RBCs inside macrophages, what is termed as erythrophagocytosis. Hemibiasis is going to be characterized by fecal transmission of entamoeba histolytica and is going to be causing the development of a flask-shaped ulcer. The patients are going to be having the ulcer present in the cecum, and sometimes the trophozoites can be moving from the gut into the liver, where they can result in development of amoebic liver abscess characterized by Anchovius pus in the liver. So what we are having over here is an example of a picture wherein because of tuberculosis, patient is having a stricture formation. What we are having in case of enteric fever is presence of an ulcer that is going to be a longitudinal ulcer. And what we are having in case of amoebiasis is patients are going to be having a flask-shaped ulcer. We should not be forgetting about an example of inflammatory bowel disease, which can also be having the presence of ulcer formation over here, which is Crohn's disease. And Crohn's disease is going to be characterized by the presence of snake-like or serpentine ulcers. Having said that, let's quickly have a recap about the malabsorption disorder. One of the common reasons for development of an infectious cause of malabsorption is giardiasis, also called as Beaver's fever. Giardiasis, as you may be able to recall, is responsible for causing the villi dysfunction, and this is going to be associated with a pear-shaped organism having two nuclei, binucleated appearance, which is also given the other important name of grand old man of the intestine. Grand old man of the intestine. When we are talking about the other infectious condition, we are reminded of Whipple's disease, which is caused because of a bacteria which is given the name of Trophiema whippleyi. This bacteria is responsible for attracting the macrophages, which are responsible for luminal obstruction of the lymphatics, and that is going to be contributing to the development of malabsorption and diarrhea. The patients who are going to be having Whipple's disease are going to be having an important feature that they are going to be having the presence of foamy macrophages which are having a foam-like appearance present in the lamina propria. And because of the bacteria, the characteristic finding that we have over here is PAS-positive diastase-resistant granules. Remember the fact, PAS-positive diastase-sensitive granules are associated with glycogen. But because this is not glycogen, it is a bacteria which is present in the lamina propria. So you're going to be having the presence of PAS-positive diastase-resistant granules over here. The other important cause of malabsorption can be an example of a condition which is associated as an autoimmune disorder associated with HLA, DQ2 and DQ8. And the patients are going to be having an immune response to a component of the food that is given the name of gluten. Gluten sensitive enteropathy, therefore, is the other name that is given to celiac disease. And importantly, the cereals which contain gluten include barley, rye, oat, and most notorious of them happens to be wheat. In fact, wheat and wheat's refined products like maida, like suji, even they are responsible for causing the trouble in the patient. Because gluten is responsible for stimulation of the immune system, so these cells, the CD4, CD8 T cells, are responsible for causing extensive damage to the villi. The villi are therefore going to be having an atrophy, and the patients are also going to be having the presence of hyperplasia of the crypts. Now you have a villus atrophy and you have hyperplasia of the crypt, so overall mucosal thickness remains unchanged. I repeat that, overall mucosal thickness remains unchanged. Why should we be familiar with Whipple's with Celiac Pro is because the fact such patients are always at high risk for suffering from a skin condition or a complication which is given the name of dermatitis herpetiformis. The IgA antibodies are going to be responsible for the pathogenesis over here. Long-term complication of having this disease is that patients are at high risk for development of small gut, or they are going to be having a high risk for development of GI T cell lymphoma. So that is what we need to have an idea over here. Just having a look at the important images, the presence of foamy appearance of the macrophages, pass positive dienestase resistant granules, presence of blunting of the villi, and presence of hyperplasia of the crypts. That's a feature of celiac disease. And of course, you're going to be having the presence of the pear-shaped organism, the bilineated organism. That's going to be seen as a feature of Giardia. Of course, you should be aware of the fact that the historical association between Giardia and the guy who discovered the microscope as well, Anton von Leeuwenhoek, right? That's what we need to remember. So far as inflammatory bowel disease is concerned, multiple questions which were asked in the exam, especially in 2024 as well, with respect to the inflammatory bowel disease. We have got two variants. One which is going to be given the name of Crohn's disease, an example of a condition which is characterized by abnormal activation of the gut immune response against the microorganisms, typically going to cause involvement of the ileum. That's a common site which is going to be affected. This condition is going to be having the presence of a transmural inflammation. There is going to be presence of edematous mucosa along with the presence of ulcers, so responsible for having the term cobblestone mucosa. And because of the inflammation, the fat is going to be pulled in, so it is going to be given the name of creeping fat. Remember that in case of Crohn's disease, you have a very important role that is being played by the Th1 cell, so it is going to be associated with a microscopic finding of a granuloma. Patients having Crohn's disease would be having the presence of an autoantibody, which is going to be given the name of ASCA, that is anti-Saccharomyces cerevisiae antibody. Grossly, if you look at the gut of these patients, they would be having the presence of skip lesions. And the areas where the inflammation is present is going to be having extensive deposition of the fibrous tissue. This is also a situation where the bowel becomes very fragile. So patients are at high risk for development of stricture formation as well as fistula formation. One of the commonest sites for the fistula formation in these patients happens to be the perianal region. So far as the extensive fibrosis is concerned, that can be responsible for causing the development of a string sign, which can be seen radiologically. So that's given the name of string sign of Kilter. So those are the important images wherein you are having the presence of cobblestoning of the mucosa, edematous mucosa, and between you have ulcers. You're going to be having the presence of a granulomatous lesion over here because of the Th1 response. All the four layers are affected, a transmural inflammation, most commonly seen in the ileum. Narrowing of the lumen can be appreciated over here, which can be associated with the term, the string sign. In complete contrast, if you're talking about a condition like ulcerative colitis, this is going to be involving predominantly the rectum. It's a superficial inflammation, so the part of the gut affected includes mucosa and submucosa. Patients sometimes can be having a severe inflammation, which can be causing involvement of the complete large intestine, pancolitis. And because the disease progresses in a reverse fashion, you may recall, it can result in a complication or an association backwash ileitis. This condition does not involve Th1. It is in fact an example of a Th2 mediated response. Therefore, this condition is having no granuloma formation. It can be having the presence of cryptapsis. The antibody that we have over here is given the name of P-ANCA, and one of the important markers suggestive of an active stage of inflammation happens to be calprotectin. In contrast to Crohn's disease, ulcerative colitis is an example of a continuous involvement of the gut. Because of the edema, this patient is going to be having a loss of frustrations normally expected to be seen in the colon, and therefore these individuals are going to be having the presence of lead pipe appearance. If there is involvement of the muscle plexus, if there is involvement of the nerve plexus in the muscles, then this can result in a decrease in the motility, which can result in a complication which is given the name of toxic megacolon. And this condition is going to be having an important association with a liver and hepatobiliary system condition as well, which is given the name of primary sclerosing cholangitis. All in all, why we need to be familiar with this condition is because of the fact both these conditions, Crohn's disease and ulcerative colitis, are characterized by a higher risk for development of the colon cancer. These are the important images about which we need to have an idea. Extensive inflammation of the complete large intestine associated with the term pancolitis. Presence of inflammation in the crypts area, which is going to be given the name of cryptapsis. And of course, you're going to be having a smoothening that you're going to be experiencing over here with respect to the involvement of the large bowel in a patient having ulcerative colitis associated with the term lead pipe appearance. Having said that, a special mention of a term which is being given the name of pseudomembranous colitis, very important for you for your practice as well. In case a physician happens to give a patient third generation cephalosporins, then there is a high risk of development of an infection caused by the bacteria Clostridium difficile. This bacteria is responsible for causing release of a toxin, because of which there is going to be release of an exudative material, and this exudative material is going to be responsible for giving a dirty looking appearance to the bowel. Microscopically, you could be having the presence of a mushroom-like growth or the presence of a volcanic eruption due to the debris. And this is a condition that is given the name of pseudomembranous colitis, also called as antibiotic-associated colitis, which may respond that if you give antibiotics sufficient to kill the Clostridium difficile, the patient is going to be having a remission, right? If you're talking about the colonic polyps, we can have lots of polyps, say for example, the serrated polyps or the hyperplastic polyps or the juvenile polyp or the Peutz-Jeghers polyp. Hamartomatous polyps deserve our maximum attention. First example of a hamartomatous polyp that is to be remembered is a juvenile polyp, which is seen because of an involvement of a gene that is given the name of SMAD4. This polyp is going to be associated with in children involvement, pediatric involvement, classically less than 4 years of age. And these patients can be having the clinical presentation in the form of a rectal bleed. Microscopically, a child having a rectal bleed, if you take a biopsy from the polyp, would be showing you the presence of cystically dilated glands. Cystically dilated glands. So keywords are involvement of a polyp in a young age group, having the presence of a rectal bleed and having the presence of a cystically dilated gland. In case multiple polyps are present in case of an individual, that is associated with high risk of development of a bowel cancer as well. The condition is given the name of juvenile polyposis syndrome. So lots and lots of mucosa-filled, mucin-filled glands in the lamina propria in a patient who had the rectal bleed, that is suggestive of juvenile polyp. The other polyp is what we expect to see in the second decade of life, which is given the name of Peutz-Jeghers polyp. Peutz-Jeghers polyp is going to be characterized by a problem in the level of STK11, that is serine threonine kinase. The patients classically are going to be having an age around 11 years, so second decade of life. They would be having a presentation which is going to be causing the development of a polyp in the jejunum. Such patients are known to have either the development of abdominal pain and bleeding, or they can be having a development of intussusception. Why we need to talk about this kind of a condition is that some of the patients, if you look at this polyp microscopically, this is going to be having the smooth muscles infiltrating the lamina propria. When smooth muscles infiltrate the lamina propria, we have an arborizing pattern, what is also called as a Christmas tree pattern of the smooth muscles. If an individual is going to be having multiple Peutz-Jeghers polyp and he's also having the presence of a hyperpigmentation of the oral mucosa, that is a condition that is given the name of Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is going to be associated with high risk for development of cancers in the patient, very strongly associated with pancreatic carcinoma. Let's have an important look at the important findings associated with the polyps over here. So juvenile polyp, which is going to be having the presence of mucin-filled glands, which are present in the lamina propria. When you're talking about Peutz-Jeghers polyp, you're having the presence of smooth muscles infiltrating over here. That's going to be associated with the arborizing pattern. And when you're talking about Peutz-Jeghers syndrome, you have multiple jejunal polyps, Peutz-Jeghers polyps, and you have pigmentation of the oral mucosa, including very prominently the lips. Of course, no discussion can ever be complete unless and until we always make a mention of something called as adenomatous polyp, which is an example of a neoplastic polyp. Adenomatous polyps are going to be produced because of a dysfunction at the level of a gene that is given the name of the APC gene. This gene, if it is going to be altered, is going to be associated with the presence of increased number of adenomatous polyps, and that can be associated with development of a condition that's given the name of familial adenomatous polyposis. For making a diagnosis of familial adenomatous polyposis, you need to have the demonstration of at least 100 adenomatous polyps. And these individuals can be having several subtypes histologically. It can be an example of a villous polyp, it can be an example of a tubular polyp, or it can be an example of a tubulovillous polyp. Villous polyps are going to be the most dangerous ones because they have high degree of dysplasia. Tubular polyps are going to be having the maximum prevalence. That's exactly what is mentioned over here. That is what we are supposed to keep in our mind for cracking the questions over here. Whenever we are going to be talking about special syndromes, more important from perspective of INA exam, we need to remember about the Cronk-Hitte-Canada syndrome. Cronk-Hitte-Canada syndrome is going to be a condition in which patients are going to be having multiple findings, including the presence of the skin and nail problem. So there is onychodystrophy, nail problem, thinning of the nail and splitting. Patients are going to be having skin problem in the form of alopecia. They would be having anemia and they would be having the presence of multiple GI tract polyps. Such patients quite frequently are going to be having a suppression of their appetite as well. So they are going to be having cachexia. And why do we need to talk about the Cronk-Hitte-Canada syndrome is that these patients are at high risk for development of colon cancer. So presence of cachexia, presence of alopecia, presence of anemia, and the presence of nail problem, that is splitting of the nails and thinning of the nails, that's a feature of the Cronk-Hitte-Canada syndrome. We were asked a question 2022 exam about a syndrome that is given the name of the Peat and hamartoma syndrome. and that's also being given the name of the Cowden syndrome. Cowden syndrome, you have the involvement of chromosome number 10. What these patients are going to be having is what a lot of you would be remembering. And as I always say about the fact, the best of you are going to be remembering it. So these patients are going to be having a high risk for development of breast cancer. There's a high risk for development of endometrial cancer. There's a high risk for development of skin tumors and high risk for development of thyroid cancers. So because of its association with thyroid cancer and endometrial cancer, it is likely to be asked in the exam, the Cowden syndrome. So Cowden, Cow10, that's how we remember it. Chromosome 10 dysfunction that is going to be seen in the patients. Having said that, let's have a look at the neoplastic polyp with respect to its appearance. So tubular adenomas are going to be having the presence of tubular glands, which are irregular glands, which are going to be present, high prevalence. Villous adenoma are going to be having villous projections like this. So very dangerous because high chance of dysplasia and progression to cancer. And if both of them are coexisting together, that's called as a tubulovillous pattern. Interestingly, patients who are going to be having a villous adenoma, they are the ones who are going to be having a clinical presentation in the form of development of a diarrhea, right? If you're talking about a condition, genetic conditions which can be associated with colon cancer, one of the prominent conditions asked in our exams time and again, friends, happens to be the HNPCC syndrome or the Lynch syndrome. HNPCC syndrome is an autosomal dominant condition because of microsatellite instability, and the reason happens to be a defect in the DNA repair genes. These patients are going to be having the cancer arising from the proximal bowel, and more commonly, patients are going to be having colon cancer, they'll be having endometrial cancer, they will be having ovarian cancer. So the Lynch syndrome is an example of what we try to remember as the CEO syndrome. The second one, which is remembered often by a lot of people, happens to be familial adenomatous polyposis, for which I already had a discussion. You need to have the presence of at least 100 adenomatous polyps who are demonstrating this, and this is going to be seen because of a mutation in chromosome number 5. Patients are going to be at times having the presence of 3 types of variants. One which is going to be given the name of a classical variant. Classical variant patients are only going to be having more than 100 adenomatous polyps. They are also going to be having ocular problem in the form of retinal pigment epithelial hypertrophy. Some patients are going to be having FAP, plus they are also going to be having CNS tumors. So that's called as Turcot syndrome. There can be a third subset of patients who can be having FAP, plus they are having other tumors like soft tissue tumors, plus they are going to be having the presence of desmoid tumor. They could be having the presence of something like the bone tumors like osteomas. Those are given the name of Gardner syndrome. So classic FAP, Gardner syndrome, Turcot syndrome, these are the 3 terms that you need to remember in association with the familial adenomatous polyposis. Apart from Lynch syndrome, apart from familial adenomatous polyposis, there can be other risk factors for development of colon cancer. For example, any patient who is going to be having inflammatory bowel disease, any patient who is going to be having a high consumption of dietary lipids, any patient who is going to be having a chronic constipation, and any patient who is going to be having the presence of Streptococcus bovis endocarditis. Such patients who are going to be having colon cancer are quite commonly going to be having a clinical manifestation in the form of rectal bleeding. Patients are going to be having additional findings like tenesmus and spurious diarrhea. Gross appearance that we are going to be having in the colon is going to be given the name of a napkin ring appearance. And because it is an adenocarcinoma, so you would be having the presence of a glandular pattern with respect to this kind of a cancer. Microscopically, you could be having the presence of a situation where mucin granules are present on one side of the tumor cell, which is going to be associated with the term signet ring appearance. So gross appearance, adenomatous polyps, multiple polyps are present in the patient. Napkin ring appearance, the constricted area because of the presence of infiltration of the cancer. And radiological sign that you have over here is apple core appearance. One of the ways by which we can definitely make a diagnosis of this cancer is going to be colonoscopy coupled with biopsy. Biopsy shows you presence of glandular pattern. And of course, if you are going to be looking at the tumor markers, one of the important tumor markers that you're going to be having for this condition is the carcinoembryonic antigen. Right? So that is what we need to remember so far as the discussion is concerned. Of course, this is just a representation of the variants. Now, winding up our discussion by talking about the anal carcinoma. Anal carcinoma is going to be an example of a squamous cell carcinoma because most of the times it is going to be having its origin below the dentate line. It's an example of a cancer which is going to be having a response to anti-cancer drugs as well as radiotherapy. So this combination of anti-cancer drugs and radiotherapy is given the name of Nigro's regime. Surgery is not performed routinely in the patients, of course, because of the high risk for development of a complication like the incontinence. So this is what is going to take care of a discussion of the important conditions associated with the GI tract. We'll now talk about the next topic in systemic pact, and that is going to be a discussion of the hepatobiliary system. Now, when you talk about the hepatobiliary system, let us first start off with the basic facts with regards to the disorders affecting the bilirubin metabolism, because of which the patients are going to be having a clinical presentation in the form of jaundice. If we talk about jaundice, we can subdivide jaundice into two categories. One in which the patients are going to be having the presence of unconjugated or indirect hyperbilirubinemia, or we could be having conditions in which the patients are going to be having the development of conjugated hyperbilirubinemia. As and when we are making a mention of unconjugated hyperbilirubinemia, practically the most important condition that we need to remember over here is going to be hemolytic anemia. But with respect to the exam MCQs, we are asked about certain types of syndromes. One particular syndrome which is to be kept in mind over here is a condition that is given the name of Gilbert syndrome, which is an example of an autosomal recessive condition in which there is going to be a reduced activity of an enzyme that's called as UDP glucuronide transferase. The patients are going to be having a development of a jaundice, particularly in the presence of a stressor, some kind of a stress, maybe infection, maybe fasting, or the patient is having a stress and is typically going to be an adult individual. So Gilbert is an adult individual having a history of stress, fasting or infection, and then he develops a jaundice. In contrast, we have a condition that is given the name of Crigler-Najjar syndrome, which is seen in case of babies. This condition is going to be having a trouble that there is going to be either a complete deficiency of the enzyme, that's called as Crigler-Najjar syndrome 1. There is complete deficiency of the enzyme, and these babies are going to be having a fairly low chance of survival. Still, we try to give them phototherapy, but they are going to be having a morbidity or mortality because of connectors. Crigler-Najjar syndrome is an example of a condition type 2 in which there is an enzyme but it is underactive. So if you stimulate the enzyme, the patient is likely to get better, and therefore this is an example of a condition which is going to be responding to drug therapy with the help of phenobarbital. If we just look at the conditions associated with conjugated hyperbilirubinemia, conjugated hyperbilirubinemia would be an example of a condition which can be caused because of primarily either an obstruction. The obstruction can be commonly caused because of, in the clinical practice, gallstones. There could be an example of a parasitic infection associated with this. That's going to be something like a cholangiocarcinoma, or the patients are going to be having some kind of a fluke infection.